interpret some of the images yourself. So that's why we're going to be spending a bit more time on it. What I will do is I will go through and give all of you the chance to present one case. But I will also be throwing out other questions randomly to everybody. This is fairly relaxed. If you're struggling with the answer, we will throw it open. So I hope that you actually, as well as learning something, you actually enjoy this tutorial. So let's start, first of all, with head trauma. And hopefully you've looked at all of these images before. And hopefully you've also revised your anatomy and some of the lectures that you had in year 4, because some of the stuff that we're doing now is covering what we did in year 4. Okay, let's actually, before we start, let's have a quick look at CT in general. So I think you already know all this, but maybe I can get all the girls. Can you please start to type what is hyperdense on a CT scan? So all the girls, can you type what is hyperdense on a CT scan? Bone, yes, very good. Very good, bone, yes. You can all see this. Can everybody see? Everybody can see the answers. Blood, bone, calcification, good. Any more? Yeah, any more? Acute bleeding, so acute blood. 2 more things. Things that we don't actually usually need for trauma. Foreign bodies, good. So foreign bodies like shunts, and something else that we do to patients. Contrast, very good. So basically, bone and calcium come together, if you like. They're both very dense. Then we've got the pathology, which is really acute hemorrhage. And then we've got 2 things that we do to patients. So we give them contrast, and we may put in shunts or bullets. So those are all hyperdense. Okay, so what is, and this could be to the boys, can you type 3 things that are very hypodense? That's black. What is black on a CT scan? CSF, very good. Air, yes. One more. CSF and air. Can you all type one more thing that is black on a CT scan? Fat. Well done, James. Fat. Absolutely. So those are the 3 things that are black. Right, now can you all start? For isodense is a bit difficult. There is one pathology, or there's some pathology can be isodense, which means it can be quite difficult to see on a CT scan. For trauma, we'll see this would be a subacute subdural hemorrhage. Sometimes there are very small tumours that you really can't see until you give contrast, but isodense is a rather small area. I think a bigger area is hypodense. And by hypodense, I just mean not black, but darker grey than the brain on the opposite side. And so can you all start typing, what pathologies are hypodense? So most hypodensity, we're talking about pathology. What pathologies are hypodense? Can you all start typing? What pathologies are hypodense on a CT scan? Anybody can answer this one. Boys, girls, sorry, ladies and gentlemen. Yes, so chronic blood. So yes, if you damage the brain for any reason, then it can, over time, it can become hypodense. Yes. Ischemia. Yes, very good. Anything else? Okay, the answer to this is actually, it's quite simple. It's nearly all pathology, with the exception of things like acute hemorrhage. There are a few tumours that are slightly hypodense as well, like melanoma, but they're rare. So basically, most pathology is hypodense. So think for pathology. Infarct, ischemia, edema, tumours, cerebritis, all of those tend to be hypodense. And that's why on a CT scan, we often need the history. Has there been trauma? Are there neurological deficits? And sometimes we need to look at the distribution of the abnormality. And occasionally, not for trauma, but for other things, we may need to give contrast. So most pathology except for acute hemorrhage, is going to be this sort of grey colour when you compare it to the other side. And so this is just a reminder of what we've just done. So, of course, we're talking about density on CT. Sometimes you will also hear the word attenuation. So it's the same thing. Hypodense is the same as low attenuation. Hyperdense is the same as high attenuation. So this is just what we've been talking about. Very hypodense. Air. Fat. Can you see the fat underneath the skin? Here. And fluid. That can be CSF. It could be fluid in a cyst. Hypodense is most pathology. This is contusion because of, we're going to be talking about trauma, but most pathologies are hypodense. So they're dark grey. Isodense, in context of trauma, it's usually a subacute subdural, which we will talk about in a minute, same density. And hyperdense will be things like acute hemorrhage, bone, calcium, and here we've got a shunt. Other things would be IV contrast if it was given. So these are the various densities that you're going to see. Now, just quickly to go back, if we look at the very first image here, can you see that the brain isn't the same density? The white matter, which is coming out here, so the white matter is around the ventricles and then it spreads out. And it spreads right up to the edge underneath the cortex. So the white matter actually looks a little bit grey on a CT compared to the grey matter. So where's the grey matter? The grey matter is around the edge. So this is the cortical grey matter. And the grey matter is also centrally in the basal ganglia. So on a CT scan, the grey matter looks a little bit whiter than the white matter. But what I'm getting at is when you compare it to the other side and the density, you're deciding if it looks more grey than the white matter or more grey than the grey matter when you compare with the other side. Okay. So this is the same thing again. Now, we're going to start now with the head trauma tutorial. What we will do is we will do the tutorial and then we will take a 5-10 minute break and then we will do the next one. So let's start with the head trauma. Does anybody have any questions, first of all, about density? Any questions about density?
Sorry, Professor, I wasn't here when you take the attendance because I arrived late.
Oh, hello. Fine.
So
sorry. Yes, Lung Hai Hong. What shall I call you?
Marcus.
Marcus.
Yeah.
Let me just find you on my list. Marcus. Good. Okay, Marcus.
Okay, thank you.
Anybody else who wasn't here when we took attendance? Philip or Ho Chi Wan? Philip Fan? No? Ho Chi Wan?
Oh, hi. This is Philip.
Hello, Philip. Hi. Can you put your camera on and just say hello?
Oh, I'm still traveling because my neighbor's place is under construction. I'm trying to find somewhere that's quiet. It's really noisy in my room.
Oh, okay. Fair enough. Okay,
Sorry.
Philip. Okay, fine. Philip, I believe you. It's the best excuse I've ever heard if it's not a true one. So, okay, fine. All right. Thank you, Philip. So we're just missing Ho Chi Wan. Oh, and Alvin. Alvin Leung. Are you there, Alvin? Not yet. Okay.
Ho Chi Wan,
Yes.
she typed in chat box saying that her camera is not working.
Sorry, camera not working. Okay, can you unmute yourself and say hello? Ho Chi Wan, can you just unmute and say hello? Nothing working.
Hi.
Hi. Hello.
Yes.
Fine, I can hear you. That's
okay,
good.
Okay.
Ho Chi, what shall I call you?
Derek.
Derek. Okay. Fine. Okay, so we're only missing Alvin at the moment, I think. Alvin Leung. Okay, right, let's go on. So let's start. So just a reminder, when you're looking at a head CT scan, you have to be quite systematic. So you're going to look for fractures, linear or depressed. Next, you're going to look for collections of blood outside the brain, which is going to be a subdural or an epidural. And then you look for injury inside the brain, which is contusion that may or may not have hemorrhage with it, and also diffuse axonal injury. And I put subarachnoid hemorrhage at the end because it's also important to look for. It tends to be more minor in primary tumours, in primary trauma. But we'll talk about that in a moment. Then I want you to comment on whether there's any mass effect. And by that, I mean whether you can see that the ventricles are compressed or the midline is shifted to one side. Brain herniation, we don't really have a lot of time to go into that. I don't know if I've got there is a quick image just to show you. So this is the main thing, shift of the midline. And here you can see the compression of the lateral ventricles. For brain herniation, for time we won't comment on it, but just to be aware that the brain can herniate in three main ways. The frontal lobes can herniate underneath the falx, that's subfalci. Then there can be herniation through the tentorium. So this is the gap where the brainstem passes up into the supratentorial region. And the part of the brain that's closest to this gap is usually the uncus, so of the temporal lobe. So we often see uncal herniation. But sometimes just the whole of the brain, including the basal ganglia and the thalami, can also be pushed down. In this case, what you'll see is those cisterns, the basal cisterns, are effaced or they're compressed on one side or both sides. And then finally, if you go to the posterior fossa, you have the cerebellum, and the lowest part of the cerebellum is this cerebellar tonsil, and that can get squeezed through the foramen magnum, which is a very tight space. That's tonsillar herniation. But I just really want you to concentrate on this one, midline shift and compression of the ventricles. Okay, case one. So this is a patient who's had trauma and there's an abnormality, and I want you to describe it, because in an exam, if you describe things, you get marks, and then give the diagnosis. And then I will ask a second person to describe another abnormality and give the diagnosis. So let's just slowly, quickly, and then there's a third question, which I will open up to everybody to ask whether, in fact, I will probably ask this question to the second person. So this is the scan to give you an overview. And I'm going to slowly scroll through it just to remind you. Now, hopefully you've looked at these scans before you came to the lecture. Okay, so I'm going to go back, and I think I'm going to stop at probably this one. Let's stop there. So, Gabriel, you were up bright and early this morning. Can we start with you? Would you mind trying to present this case for me? Gabriel, are you there? You can tell. Yes, hello, morning. Yes.
So this is an axial CT scan of the brain at the temporal region, and the most striking feature is a right-sided biconvex shaped hyperdensity.
Yes.
At the right parietal region.
Good. And inside or outside the brain?
It seems to be outside of the brain.
Yes.
So my top differential would be an epidural hemorrhage.
So acute epidural, something? Yes, they're usually acute. So
acute.
Yes, fine. Good. Absolutely. Is there mass effect?
Yes, there's mass effect to the left side of the midline.
Yeah, so the midline shifted. What about the ventricles? Are they compressed?
The lateral ventricles appear.
Good. So you can see the occipital on this side, and it's gone here. And it looked also being a little bit compressed in the frontal horn here. Very good. So absolutely, this is an acute epidural hemorrhage. You described it beautifully. So it's a shape that tells you that it's not a subdural. So subdurals and epidurals are outside, they're extraaxial. The shape tells you which it is. This is the biconvex or the lens shape. So in general, are you worried about this patient, and what would you do next?
Yes. So I would first resuscitate the patient.
Yeah, well, maybe I don't need it yet, but yes. No, you're absolutely right. This is very serious. Yes. So what is your next investigation or next action?
Perhaps a CT of the like a full body CT because maybe other trauma.
It could be. So yeah, if there was a history of like road traffic accident, then probably what happens here is that the whole scan would be done in one go. Sometimes it's just a history of head trauma and all they have is the scan. So all we've got is this scan. What would you do next? An action. It doesn't have to be an investigation. What would you do next?
I think.
There you are, middle of the night, no one's around, you've looked at this.
Offer help.
What are you going to do? Offer help, absolutely, good. You pick up the phone. The next thing you do is pick up the phone and you get the neurosurgeon as quickly as possible. Now, of course, any hemorrhages like this outside the brain that's causing mass effect is important and serious. But why, Gabriel, are we more worried about the epidurals? What is it about the epidural that makes us extremely anxious? So I'm just going to see if I can start to, while you're doing that, I'm just going to see if I can record just for my future. See if I can record.
Recording in progress.
Yes.
I guess because it might have damaged the artery in.
Yes, which artery are you worried about?
Is it called?
Does anybody want to help? Anybody? Is this anybody help Gabriel? Which artery do we get worried about?
Middle.
I'll come to you in a minute, won't it? I know you're.
It's like in the Tarian, but I don't remember what it's called.
So anybody want to type? Middle meningeal, absolutely. So middle meningeal artery, yes. So the thing about epidurals is they've usually damaged a major vessel, most likely the middle meningeal artery, but it can be a sinus, such as the transverse venous sinus. And as a result of that, unlike subdurals, which is the small cortical veins, epidurals are big vessels. So you think about it, you do not want blood pumping in to this area because they can rapidly accumulate, rapidly cause mass effect, and rapidly cause death. And so, as you know, the history of this is often somebody may have had some trauma, maybe they lost consciousness, then they come around and they're fine, they go off for something to eat, and they collapse. Yeah, so that's a typical history. So it's often injury, young people, sports injuries, they're skiing, they're playing contact sports, they have a head injury, and then they lose consciousness and then they come round, but later on, suddenly they get worse again. So this has to be evacuated very urgently. Good, right, well done. So let me move on to Michelle. Michelle, are you there?
Hello, yes.
Hello, Michelle. Right, this patient had another abnormality though. They have this blood here. Where do you think this blood is?
Where?
Yes.
Uh,
Do you think it's inside the brain, outside the brain? Do you think it's related to the trauma?
I think it's inside the brain.
Right.
So
intraaxial.
I guess it's related because it looks acute as well.
Yes, absolutely. So very good. It looks as if it's happened about the same time. Good, because it looks hyperdense, acute. This is a really tricky one. Does anybody think that it may be extraaxial, outside the brain? And if it were extraaxial, where would it be? And the clue is always look at the other side. We're always given two sides, which makes it much easier to.
Is it like one of the fissures?
Oh, well done. Very good. Very good. This is the Sylvian fissure on this side. Here it is on this side. So if you go down, so the Sylvian fissure on the axial always looks like this vertical slit. Here it is again. Can you see the shape of this is exactly the same as the shape as this on all your scans? So this is in the Sylvian fissure. So this blood is epidural, subdural, subarachnoid.
Subdural.
So it's probably subarachnoid. So this patient has got a subarachnoid hemorrhage in the sylvian fissure. So my question was, do you think that this is caused by the trauma? The answer actually is yes, of course it could be, because you can get subarachnoid hemorrhage. But is there anything else you should be thinking about?
Like this causing the trauma?
Yes.
Like
what are the other causes of subarachnoid hemorrhage?
ruptured aneurysm?
Good. What happens if you rupture an aneurysm?
You get bleeding and a stroke.
Yeah, and what else? You lose consciousness, yeah? If you lose consciousness, what can happen?
Fall.
Fall over. And then what happens if you fall over?
Hit your head.
Okay, good, absolutely. So if you're driving a car, for example, and you have a subarachnoid hemorrhage, you lose consciousness, you have a road traffic accident. You're working on scaffolding, subarachnoid hemorrhage, you fall off. So these patients may come to you as trauma. So just be aware, particularly when you've got blood like this, there's a lot of blood in the sylvian fissure. That's a very common site, isn't it, for a berry aneurysm. So make sure you take a good history, because it may be that they have two pathologies. They ruptured an aneurysm first. They fell over, they had the head trauma, they got the epidural. So they could have two pathologies. Yeah, good. Well done. Right, good. Let's move on now to Dominic. We'll ask you the next question. Oh, sorry, just to go back, when you're presenting, you could start with something like this is an abnormal CT scan. And I know everybody loves to say the most striking abnormality, but in an exam, sometimes an examiner might think something else is more striking. So you might be best just to say, this is an abnormal CT scan and I see this X. And then if you're in a viva, you won't upset an examiner if he thinks that something's more striking. Okay. But you were quite right. It is striking, but just the way to present it. Okay. Something else, just to go back. This epidural, can you see these low density areas? This often suggests that there is flowing blood. So there is acute bleeding going on. So again, this is a bad sign. So this patient had a ruptured aneurysm. They then had trauma. They then got this, there's usually a fracture, you can't see it, but usually this is the site of impact with a fracture. They damaged the middle meningeal. I agree this is quite high. This is up more in the parietal lobe. We do usually see them more in the temporal, but there's a little bit in the temporal. So maybe it's a peripheral branch. And then they've come in with the trauma. And this is a real emergency. This patient's about to cone and die, so they need something done very quickly. Okay, Dominic, question for you. Describe the abnormality and give the diagnosis. And then I will go on and ask Grace if you could then describe another abnormality and give the diagnosis. So let's start with Dominic. So Gabriel, you can turn off your camera now. And thank you. So, and then I'm going to open this open to everybody. What's A, B, and C? So this is the scan. And it looks like this. Same history, patients had trauma. In fact, I could go back. While we're here, in fact, let's everybody type. Can you all type in for me? A and C are the same thing. What is A and C and what is B? Can you all type? What is A and C and what is B? Anybody typing? Can you all type for me? If you don't know what both of them are, it's fine. Just type one. If you know what any of them are, just type for me. I seem to, well done. A and C is choroid plexus. Very good. This is the choroid plexus and this is the ventricle. So the choroid plexus, particularly posteriorly here, can calcify. What's B? Where is that calcium? What structure is right in the midline at the back of the third ventricle? Pineal. Well done. Absolutely. Pineal gland. Very good. Right. So let's move back to Grace. So I'm going to ask you to describe one abnormality, Grace, and we'll start here. Can you describe one abnormality? That's it. Yes. Hello.
So this is an abnormal CT scan of the patient, like CT brain.
Yes.
I can see a hyperdense crescent shape lesion at the. Is it?
You can point. Are you able to point with a cursor? Not. Maybe you can't. It's not always. If you can do it easily, we'll do it. If not, don't worry.
Let me see. I don't know how to annotate.
Okay,
Sorry.
don't worry. But maybe later on in the break, you can all check and just see. But you're absolutely right. It's on the right side. It's intraaxial or extraaxial? Inside the brain or outside the brain substance? So intraaxial means inside in the temporal lobe, in the parietal lobe, in the occipital lobe, in the pons. Extraaxial means anything outside the brain.
I think it's outside.
Good. So extraaxial, you described it beautifully. What do you think it is?
I think it's a subdural hematoma.
Good. What age is it?
Because it's hyperdense, so it's acute, which is less than 1 week.
Yes, very good. Actually, you do. Why did you continue? Actually, while you're, can you see another abnormality?
Like in this picture?
Yes.
I think there is some hypodense crescent shaped lesion also in the frontal, right frontal lobe.
There is a little bit here. It is a little bit isodense, yes. So here's the acute subdural. Do you see anything else? Maybe I go on.
Isodense crescent shaped lesion at the left parietal.
Very good, good. So there's bilateral. So can you see the edge of the brain? Here's the sulci. Here's the edge. In fact, the edge goes all the way along here and here. And outside is this crescent-shaped isodense. So what is this?
It's also a subdural hematoma, but it's more subacute.
Good, very good. So we've got an acute, maybe with a little bit of a subacute component here, and a subacute one here. Well done. Okay, good. Mass effect?
There's no midline shift.
Yes, there's no midline shift. And it's difficult, I think, when it's bilateral to comment on the ventricles. Good, very good. Can you all start typing? Which year did I show you this scan? Which year did I show you this scan? We've seen the scan before. Which year did I show it to you? Can you all type? Nobody's typing? Which year did I show you this scan? You've seen the scan before. Did I show it to you in year 1, year 2, year 3, year 4, year 5? When did we show you this scan? Nobody's typing. Year 5. It's a good guess, isn't it? Year 4. Yeah, I showed you the scan in year 4. And the point to make, which I made in year 4, was that if you see one subdural, look for one on the other side because they're often bilateral. And there may be no history of trauma. So be very careful in patients who cannot give a good history. So demented, elderly demented patients, patients who are alcoholic, and young children with non-accidental injury. They are patients who may have more than one trauma, can have repeated trauma, and they may not have a very good history of trauma, and they may not present on the first trauma, they only may present on the second trauma. So always look carefully. One other thing is that the shape is sometimes a little bit difficult on one scan. So scan up and down to get an overall view of whether you think this is crescent shaped, which is the shape of a new moon, like here, you can see here, that means it's subdural, or whether it is biconvex, which would make it an epidural. The other thing to note is that, as you can see, the density is quite similar to that of the bone. So a very small one is easy to miss. So after you've looked at your scan, go back and look inside the skull vault on all images to make sure you haven't missed a very small one. Equally, the isodense one, because it's the same signal, the same density as the brain, can also be easy to miss. So be very careful with the subdurals. So you're quite right. The acute one is hyperdense. It's for about a week, roughly. And then after that, it will become isodense. Okay, good. Okay, let's move on. And just one more thing, and that is, we've just talked about distinguishing the subdural from the epidural. And it's mainly on the shape, crescent versus biconvex. And that's by far what we use most of the time. But you can also look at it in regard to the sutures. And the one image you need to remember is just this one, subdural. So the subdural can cross the coronal, or if it's below, it can cross the lambdoid suture. But when it gets to the midline, it doesn't cross the sagittal suture and the falx. If anything, it tracks back up. And sometimes the only place you'll see the subdural is next to the falx here. Now, the epidural is exactly the opposite. So the epidural does not cross these sutures, but when it gets to the midline, it can cross the falx and can cross the midline to the other side. So just remember this one, and then remember that the epidural is the opposite. Okay, case 3. So this one, we'll go on now to Marcus. Marcus, so can you describe the abnormality and give the diagnosis? And then we may go on to Stephanie afterwards. So this is the scan. It may be that we just give this one to Marcus, I think. Maybe, Marcus, you can answer this one. So it looks like this. Okay, so Marcus, we're going to go back to this scan here. Marcus, are you there? Hello, Marcus. Good morning. Can you describe this one?
There are some hypodense.
Yes.
Crescent-shaped lesion in the frontal region.
Yes.
That crosses the midline.
Good. Inside or outside the brain? So in the frontal lobe or outside, compressing the frontal lobe? Outside. Very good. So extra axial. Good. I think the midline, if you see the midline is actually intact here, you can see a little bit of the falx. But you're right, it is bilateral. So what do you think? So you're looking at this crescent-shaped area here and here. What do you think that is? What could this be? So I think we've got 2 lesions, one on this side and one on this side. What could they be?
A chronic epidural hematoma.
So it could be chronic, true. Epidural or subdural? You described it as crescent-shaped earlier. Crescent-shaped means? Subdural. Very good. Good. So these are bilateral chronic subdural hemorrhages. So they're black. So just be aware that, I'll come on to that in a minute. If you look at this, one of the difficulties can sometimes be, do you think there's a subdural that's chronic, or is it a patient who's just got wide CSF spaces? As the brain atrophies and shrinks down, the space outside gets larger. And sometimes it can be quite difficult to tell the difference. But in this case, I think we can be quite confident it is a chronic subdural, not a wide CSF space, because look at the rest of the brain. There's no atrophy here. And if you look carefully, look at the edge. These gyri are flat, and the sulci are very shallow. You see here, it's very flat. Let's go back up to this one. Very flat gyri, very shallow sulci. So that suggests that this is something compressing. And one way just to show you that in a diagram, just to bring that home. So if it's atrophy, you tend to have rounded, large gyri and deep, wide sulci. That's atrophy. But if it's a chronic subdural, flat gyri and shallow sulci. One other thing just to go back about the density. So acute is white, subacute is similar grey to the brain, and chronic is black. But it doesn't suddenly happen. It doesn't suddenly decide, oh, day 7, I'm going to change from white, so from hyperdense to isodense. It's a gradual change. So very often on a scan, you will see a bit of acute mixed with subacute. So a little bit of hyperdense and isodense together. And then as you go on, you may see a little bit of isodense with the chronic together because it's a spectrum. So bits of it will change at a different time. But what you shouldn't see is acute, because that's right at the beginning, and chronic, because that's at the end. If you do see hyperdense blood and hypodense blood like this, it means that the patient has had a re-bleed, i.e., they had an acute hemorrhage, it went through the layers, it got to become chronic and black, but then the patient has bled again into it, and we call that acute on chronic. Okay. Anybody, any questions about that, about subdurals or epidurals? Any questions about subdurals or epidurals? No? Okay, good. Now let's move on. So Stephanie, you're next. So describe the abnormality and give the diagnosis. And Feng Ching, if you're just around, just in case I may be asking you another question, we may not. Again, could both abnormalities result from one site of impact? We'll talk about that at the end. So, and what is A? Okay, we'll do that question first. So here are the images, just to remind you. Okay. So I'm going to stop. Stephanie, sorry, first of all, A, for everybody, can you all type, what is A? What is A? Can everybody type? What do you think A is? EVD, extraventricular external, yeah, that's good. So it's a shunt, basically. It's an external shunt. And if you follow it, that's the tip. Follow, now I'm going up, follow, and going up, follow. And now you can see it's coming out to the exterior here. So this is a shunt that's been put into the ventricles. So what this trauma has obviously happened a few days before, and they've already had a shunt put in. So going back to Stephanie, if I can show you this one. What should I show you? Maybe this one. Stephanie, can you describe that one?
So this is an abnormal CT scan where in the right temporal lobe there is a heterogeneous lesion that is like a mix of hyper and hypodense.
Yes, very good. What do you think? It's inside the temporal lobe? Because this is the middle cranial fossa here, isn't it? Temporal lobe. Is it inside the temporal lobe or is it outside?
Inside.
Good, very good. So in the context of trauma, what do you think this is?
Like a contusion?
Good, very good. So this is contusion. So contusion may just be hypodense. It may be some ischemia, some infarction, some edema. But once you've damaged the brain and the brain has been injured, you can also bleed into it. So this is hemorrhagic contusion because there's a hemorrhagic component. That hemorrhage can sometimes just be little petechial hemorrhages, or it can get bigger like this and it can coalesce into a hemorrhage. And sometimes that hemorrhage may occur at the time of the trauma, or it may occur or get worse 24, 48 hours later. So if your patient gets worse, you need to rescan. Because if the hemorrhagic component becomes very large and causes mass effect, then that may need to be evacuated. Now, of course, if you didn't have a history of trauma, you could think, well, maybe this is an infarct with hemorrhagic transformation, or maybe it's a patient with a tumor that's bled. So there are other causes, but in the context of trauma, this was a hemorrhagic contusion. So very good. Now, I may go on. So well done. I'll go on now to Feng Qing. Feng Qing,
Yes.
are you there?
Yes.
Can you describe this? Can you see another abnormality there? I keep definitely online as well. So, Feng Qing, are you there? Yes.
At the left side
You don't have a camera. Do you have a camera? You don't have a...
Yes.
Oh, yeah. Could you put your camera... Oh, yes, of course. Yes.
So at the left side of the brain, there's a hyperdense extraaxial.
Good.
And it is convex shape.
Good. Biconvex. Yes. So this is probably
This is probably a epidural hemorrhage.
Good. Very good. So if you look at all of the scans, you can see that overall this is biconvex shape. So this is the diagnosis was a
epidural hemorrhage.
Good. This is acute epidural. Good. Can you see this area here? Do you think this is inside or outside the brain?
Inside the brain.
Good. So what could that be?
Could be brain edema.
Yes. So this is probably another area of contusion with some hemorrhage. So we've got an epidural and hemorrhagic contusion. Now, can you tie in together this abnormality here and the one that Stephanie has just described here? Do you think that they had trauma to this side and trauma to this side, or do you think it's just trauma to one side? Is there any way you could tie the two together? Difficult. May can help us. Sorry, Stephanie, you could help if you. Is there any way of just tying the two together? Have you heard of contra-coup injury? What's contra-coup injury? Feng Qing, do you remember, what contra-coup injury is? So contra means opposite and coup means head. So probably what's happened here is the patient has had direct trauma here. Probably, we can't see it. If you look at the bone window, probably a fracture. And then the brain is not fixed. The brain can move in the CSF. So if you have trauma on one side, the brain can go to the other side and it can impact on the skull vault on the opposite side. So probably the trauma was here and the brain was then pushed down and across and had trauma on the opposite side. So this is probably a contra-coup contusion. So this contusion is probably at the site of the trauma, and this may be possibly a contra-coup, the opposite side. So when you're looking for contusion, don't just look at the site of impact. It can be anywhere. You don't know if the impact went up or down or across, so you need to look at the whole brain because there may be contusion at another site. Now, question for both of you. There was another abnormality here, a very subtle one. Can anybody see? So Stephanie or Feng Qing, can you see another abnormality on here? This is tricky. Remember when I was telling you about the acute subdural? I said sometimes they can be very small. This is the same for an epidural. The very small ones can look like bone. So you have to look at the whole of the outside. If you do that on this section, can you see anything else? Does anybody want to draw? Anybody else can come in and put an arrow or draw if you see something else. Very subtle. Anybody see anything else? Well done. Yes.
I can see a hyperdense, also by convex lesion over the left, likely the temporal region.
Good. And what do you think that might be?
I think it's maybe I'll go up and down the scan to see if it's
good. Yes.
to the previous epidural hemorrhage.
Good. So very good. You did all the right things. You looked up and down. When it is this small, I have to say it's very difficult. You may not know. Is it subdural? We don't know really. My worry would be though, it's in the temporal lobe, isn't it? Temporal region rather. And of course, this is where the middle meningeal artery is. So, you know, maybe we're just a little bit worried. This could be a very early epidural. But I agree, it could also be a subdural. The importance is that you looked and you saw this is not all bone, there is something else. So very good. Right, let's move on.
I actually have a question.
Yes.
It's about the epidural hemorrhage earlier.
Yes.
The
higher up? Higher up as well?
Yeah.
Yes.
I thought it actually crossed, although it's obviously a bicomplex in shape, but
yes.
I thought it also crossed the sulcus.
Yeah, I think the thing is you can't quite tell where the lambdoid suture would be here on this scan. It may be that actually if it's there at all, it would be over here. So I think it's a very good question, but I think on this one it would be very difficult to see where the suture is because I haven't shown you.
Okay.
Yeah, and the coronal suture will be up here, so obviously it's away from here. On this one, I don't know whether the suture will be here. We can't tell for that because we haven't got the bone window. But good question.
Thank you.
Yeah. Okay, right, let's move on. Case 5. Patient with head trauma, again. So abnormality, give the diagnosis, what's the treatment and why? So this one is for Venus. Venus, are you there?
Yes.
Yes, hello. Do you want to put your, can you put your camera on?
Yes, I've turned on my camera. Hi. This is a CT scan of a skull base.
Good.
Of a patient.
What window is it? Because it doesn't look like the other ones I've been showing you.
A bone window.
Good. Normal or abnormal?
Abnormal.
Yeah, good guess. We're doing with our GPS. Do you know where the abnormality is?
There's the sphenoid sinus.
Yes.
Sinus is.
Can you point? Have you got a pointer? Are you able to point?
No. Okay.
No, don't worry if you haven't.
Yeah. I got it. This one.
Yeah, can you draw? Yes, good. There. Any more? Any other areas? Yes. In the middle? As well? Yes, you're absolutely right. Very good. So in fact, it's the whole of this area. So what's wrong? What's abnormal about it?
There's an air fluid level.
Very good.
Okay.
So the patient's lying on their back, looking up. So the fluid has dropped to the back. There's the air. It's got a fluid level. So this is an air fluid level in the sphenoid sinus. Very good. What does that mean?
There will be some CSF leakage into the sphenoid sinus.
There might be, yes. But what do you think the cause of that is? What's caused it?
Skull base fracture.
Good. Word, very good. Skull base fracture. So in this one, it's possible there's a straight line here. It's possible there's a little fracture here. But sometimes the base of skull fractures are not easy to see. If you see an air fluid level in the sphenoid sinus, that means a base of skull fracture in the context of trauma. And if you think about it, the sphenoid sinus here is right in the middle. So any fractures coming from the face can go through here. Any fractures coming in from the side along the petrous temporal bone or along the sphenoid wings and ridges. And anything coming up the back, up the clivus, can go into here. So the sphenoid sinus really is in the middle, and it's very easy for these fractures to go into the sphenoid sinus. Now, you're right, they could have rhinorrhea, because if you've got a fracture, then the CSF in the brain can go through the fracture into the sinus, and then the sinus can leak out through the nose and give you rhinorrhea. But Venus, if the CSF can get out, what could get in?
Air.
Air, and what else? What are we more worried about? What travels in the air? What could be traveling in the air?
Some pathogens.
Yes, pathogens. So we're talking about infection, aren't we? So if the CSF can get out, we're worried that the infection could get in. So what sort of fracture is this then? What do we call this? If it's open to the air, what sort of fracture is it?
Compound fracture.
Compound, very good. So this is a compound fracture. So I don't know if you've done your neurosurgery yet, as you need to check, because some surgeons will give antibiotics to cover for the infection. Okay, so just be aware when you see this, even if you don't see the fracture, it means there is a fracture of the base of the skull, and it is going to be compound. Very good. The other area also to check when you're looking at these are the mastoid air cells, because you could have fractures going through the petrous temporal bone, and again, those could be compound. They could be open to the air. Good. Right, let's move on. Venus, are you able to take your red lines off? Okay. Well done. Very good. Can you see here? Just show again. Can you see here's the temporal bones? So they've got the mastoid air cells and the inner ears here. This denser bit is where the inner ear is. You've got the vestibule. And you've got the cochlea is not shown here. So this is the petrous temporal bone, mastoid air cells, middle ear, inner ear, and this is the internal auditory canal. On this one, I think we're showing this one because you can see there's a fracture here as well. This is probably a very extensive fracture. Again, it's not on the other side. So there's a line here. Is this a fracture? It's on the other side, and there's no soft tissue swelling. But this one is asymmetrical, so this is why it's worrying. And it's possibly also coming through here. And again, if you look at this scan, you can see the fracture is actually coming through the condyle. So this is probably a very extensive fracture. Okay. Right, well done. Let's move on to case 6. Describe the abnormality and give the diagnosis. Looks like this, and this, and this, and this. So this one's okay. So it really looks like this. I'll give this one to James. Are you there, James?
Yes, hello.
Okay, hello, James. Can you describe this one for me?
So this is an axial cut of the head. This is in bone window.
Good. Yep.
So I can see a depressed comminuted fracture over the left temporal side of the skull.
Yes, it is sort of temporal. It's difficult, that level, and I haven't shown you the bone windows. It's sort of temporoparietal. It's quite difficult to tell on that one, but yes, absolutely. So it's depressed and it's comminuted. Very good. So pushed in and lots of fragments. What do you think the surgeon would do with a case like this?
Not too sure.
Yeah, okay, fair enough. So the answer is try to find out what they do when you're on the ward. Find out what they do. And just while we're on that, if you're having a viva and somebody asks you a management question, it always looks very much more impressive if you can say, when I was on the neurosurgical team, our surgeons would treat them like this or would do that. So always try to talk from personal experience. Obviously, you haven't had that experience yet, so you can't do that. But just generally, for your vivas, if you do have a viva where you're talking to an examiner, very good if you can talk about your personal experience. Now, this fracture, they would probably operate on it because there's worried there may be tearing of the dura, there's increased risk of infections and focal neurological problems. So very often they would treat this one and treat the fractures, move those fracture fragments out, repair the dura. The reason we're also showing this one is that in this case, it's quite easy to see the fracture, but linear fractures can sometimes be difficult. And this shows some other signs of a fracture. So James, could you give me 2 other signs that would tell you, obviously we know there's a fracture in this case, but what are two other signs on here which tells you there's a fracture.
It's associated with some soft tissue swelling.
Excellent, well done. So look at the soft tissues in the scalp here. Obviously, the soft tissue windows would be easier, but even on the bone window, you can see it's swollen here. Good. And there's one more clue into this.
Is there some air?
Yeah, well done. There's a little pocket of air here. Sometimes look for those little pockets of air because they sometimes give you a clue, particularly with a linear fracture. So if you can't see a linear fracture, look for soft tissue swelling and look for those pockets of air, as well as we've discussed, fluid levels in the sphenoid sinus and fluid in the mastoid and middle ear. Okay, good. Right, let's move on. This is just a 3D to show you a depressed fracture. Just remember that a depressed fracture can actually be quite difficult to pick up on a skull x-ray. Luckily for you, I don't think we would really be doing skull x-rays. As soon as there's any major trauma, the patient's going to go straight to CT. And this is just a 3D to show it. Okay, case 7. How are we doing for time? Oh, we have to speed up a bit. A patient with head trauma and multiple neurological signs. Describe the abnormality and does it account for the neurological signs? This one's for Carol. Carol, are you there?
Hello.
So let's just go through. So this is the scan.
Okay.
So I think we'll just go to there. So can you describe the abnormality?
I can see also a hyperdense. It's an axial cut.
Yes.
CT brain.
Normal, abnormal?
As an abnormal one.
Yes.
I can see there is a hyperdense lesion, intraaxial lesion that is at the left frontal region.
Yes, on frontotemporal.
In the Sylvian fissure.
Good. It's in the Sylvian fissure. Good. So where is that blood?
So it's likely a subarachnoid hemorrhage, and it's rather acute.
Very good. So as we've described before, you can obviously get subarachnoid hemorrhage related to trauma. This one was related to trauma. But one other thing, you might want to get a good history to make sure for what? What might other thing you might be worried about? Because it's in the Sylvian fissure like this.
We may be worried about some other etiology.
Yes.
Usually, most commonly can be a rupture of aneurysm.
Good. So you're going to take a good history. Very good. Sorry, carry on. Sorry, Carol.
I'm just thinking maybe family history is important too, and any previous similar episode, and whether their head trauma is before or after she have any symptoms.
Very good. Well done. So you take a good history. Now, in this case, this was just due to the trauma. So the second question is, this patient had multiple neurological deficits. Does subarachnoid hemorrhage usually cause neurological deficits? Focal. It may cause a loss of consciousness, but does it cause focal neurological deficits?
Maybe not.
No, good. So basically, although we've got subarachnoid hemorrhage, it's not really explaining why the patient's got these quite severe neurological problems. So what diagnosis is going through your mind now?
Since the patient have a trauma history, so maybe diffuse axonal injury.
Excellent, very good. So diffuse axonal injury, as the name says, it's axonal, i.e. tiny. So tiny little areas that might be hyperdense hemorrhages or hypodense, just the contusion without hemorrhage. They're often in the peripheral white matter, sometimes around the corpus callosum, but they can be anywhere. But because they're axonal, they may often be too small to see on CT. But because it's diffuse axonal, i.e. many axons, it can cause severe neurological problems. So if we don't see anything on CT, Carol, what investigation could you do next? Not acutely in the middle of the night, but maybe the next day You can't explain what's happening. What investigation would you do next?
Maybe an MRI.
Good, an MRI, because MRI is much more sensitive. It can pick up these tiny little areas. And if we go on, you will see, so you can see the hemorrhage here. This is a susceptibility weighted scan. And what this does is, if you've got a tiny microhemorrhage, it may even be too small to see on the normal MRI. But if you've got a tiny one, it exaggerates the hemorrhage and makes it look bigger. We call this blooming artifact. So tiny little areas that you can't see, even on the normal MRI, can show up. So you may see in diffuse axonal injury multiple microhemorrhages. Now, can you see, it's a bit difficult with just 1 or 2 scans, because unfortunately blood vessels can look the same. And the way you tell the difference is you pan up and down. And if you can still see it, and it looks like a tube, it's a blood vessel. But if you come into it and then come out of it again, it's just focal, means it's a hemorrhage. Can you see anything on here, Carol?
I can see some hypointense lesions.
Can you draw? Are you able to draw? Or have you?
Wait. I'm guessing.
Yes.
Maybe.
It's not easy. On just a couple of, have I shown you? Maybe.
Yeah.
Okay, here. I think this is a good guess. This is actually, can you see the problem with this sequence is that anything near air, so this is air in the sinuses and the nose, it distorts and it makes everything look black. This is actually distortion, which is coming off the air in the petrous temporal bones. One of the clues is you can see it on both sides. So I'm glad you drew around it, because it's a very good guess. In this case, this is a sequence which is very distorted by air. But maybe I'll just, for time, I'll quickly show you, because this is tricky without seeing all of the... So in fact, there's lots. There was one here, there's one here, there's one here, there's one here, one here. And as we go down there, probably one here and one here.
Oh.
So this patient has indeed got diffuse axonal injury. And why it's good to do this is you can then explain to the patient and their relatives what the likely outcome is, because obviously this is a severe trauma. Okay. Right, well done. Anybody, so just quickly, we've been through fractures, linear fractures, depressed fractures. Linear fractures may sometimes be difficult to see. Clues are soft tissue swelling, little pockets of air, and if they've gone through the base of the skull, you'll see air fluid level in the sphenoid sinus, and you may see fluid level in the mastoid and middle ears. I forgot to say, while we're on that point, if you have got fluid in the mastoid and the middle ears, and there's a fracture of the petrous temporal bone, check the hearing, because fractures can go through the nerves or the ossicles. And what you would do in that case is the next day you might do a petrous temporal bone CT, which is a very high resolution scan. And we can see the ossicles. We can see all of and how they articulate together. And we can see whether those fractures are going through the ossicles or through where the nerves are. So just be aware to look into the hearing, any hearing problem if there's a fracture of the petrous temporal bone. So linear fractures can go through the sphenoid sinus, they can go through the petrous temporal bone. If they are going through the sphenoid sinus or the petrous temporal bone, they may be compound, so the patient may need antibiotics. Depressed fractures, easier to see, and they may also need surgery to lift them out. Then we had 2 hemorrhages outside the brain, epidural and subdural. Remember, they're both important, particularly if they're causing mass effect, but the epidural is the one you really worry about. That patient can cone and die quite quickly. And don't forget that they can be, the subdurals can go through different colours, if you like, with age, from acute to subacute to chronic. And all of those can be quite difficult to see, particularly if they're small. So look very carefully for them. And then inside the brain, we looked at contusion and hemorrhages. Hemorrhages are usually secondary to bleeding into the contusion. I didn't mention, but occasionally they're primary. So, for example, a bullet going through the brain will just cause hemorrhage behind it. And then also in the brain, we've got the diffuse axonal injury. And then don't forget get subarachnoid hemorrhage, usually just part of trauma, but sometimes it could be secondary to someone who's ruptured an aneurysm. Okay, any questions? Anybody have any questions? No? Okay, in that case, everybody take a 10-minute break. We'll come back at 25 to 11. If you could try and see if you can get your drawing things working as well, that would also help. And so I'll see you in 10 minutes. Okay.
Recording stopped.
Hello, Hannes. Could you pop down now, please? Thank you. Bye-bye.
Recording in progress.
Hello, everybody. Are you back? Right, let's move on now to the second topic. So we're going to look now at stroke, again, because this is an important topic. You may need to look at these scans yourself. And of course, stroke is a very topical thing at the moment because we are a centre here that does a lot of thrombolysis. Okay. So, everyone, can you all get typing? Can you list 3 common causes of ischemic stroke? Can you all start typing 3 common causes of ischemic stroke? Are you all there? Can you all hear me? You can just type 1 cause. It doesn't have to be 3. Good. Embolism. I'm just going to turn off my a minute while we talk. Good. Keep going. Yes. Yes. Okay, good. So actually, the 3 main common causes are sort of the large vessel atherosclerosis, where you get the thrombotic plaque that will obstruct the artery. The next one is probably the one I can't see here, is the small vessel disease. So this is where patients who are hypertensive or they have diabetes, they get diseases affecting those small vessels. And the final one is embolism. So can you all start to type for me? For emboli, oh no, actually, well, for emboli, where do the emboli come from? Where do emboli that cause ischemic stroke come from? Can you type for me? The heart, good. Give me 2 conditions in the heart that can cause emboli. Good, very good. So atrial fibrillation, so patients who've got a thrombus in the left atrium, and those who've got infective endocarditis, very good. Where else do emboli come from? Where else do emboli come from? Yeah, so the carotid arteries. Now you can have carotid plaques that break off and can then cause stroke. What investigation do we do if we want to look for plaques in the carotid vessels? What imaging investigation can look at plaques in the carotid vessels? Good, very good. Ultrasound Doppler. Good. Let me just come back on again. Okay. Right, so we've done the 3 most common causes, but can you give me other causes of ischemic stroke? Can you type any other causes you know of for ischemic stroke? Okay, not many. Okay, so if you're in an exam, vasculitis, very good. Yes, which sort of vasculitis do you know of? Shahim, any other causes of vasculitis that you know of? What are the causes? SLE, very good. That's an important one here, actually. So good. Any others that you're aware of? Any other causes of vasculitis? Anyone can help Shahim? So Chihim. No, okay. Well, there are the large vessels. There are things like moya, Takayasu's. There's lots of different vasculitic entities that can cause ischemic stroke. Now, if you're in an exam and you're being asked for other causes, then you need to think systematically. So just generally, most pathologies will have 3 common causes. So make sure that you've got a list of 3 common causes. And if you're on the wards, you'll already know what they are because those are the cases that you see. But then you need a systematic way to come up with the less common causes. And you can do that 2 ways. You can either do it based on pathology or you can do it based on anatomy. So, for example, pathology would be maybe it's trauma, maybe it's metabolic, maybe it's infection, maybe it's tumor. There's a long, long list which you can apply to everything. Or you can do it on anatomy. And I think anatomy is quite good for this one. So if you did anatomy, you'd say, well, it could be an abnormality of arteries or veins. That way, remember veins, sagittal venous thrombosis is also a cause of an ischemic stroke. Go back to the arteries and then thinking anatomically, particularly it could be large vessel disease. So what can affect the vessel wall? What can be inside the vessel? So the vessel wall, we've already mentioned some of them, but another condition, what's a very important condition, should probably be number 4 on your list, that affects the vessel wall. Vasculitis is one. Another important condition that can affect the vessel wall, large vessel wall, and cause stroke, ischemic stroke. Anybody wants to type for me another abnormality that affects the vessel wall? Nobody? Okay. Yes, right. So it doesn't necessarily have to be aortic, Gabriel, but you're absolutely right, dissection. So you can have a dissection of the internal carotid artery or the vertebral arteries. Just be aware the vertebral artery is very susceptible to dissection. It's a tiny vessel. It can be easily damaged or spontaneously can dissect. And what happens is it dissects up, and then it may even go into the basilar. And during the dissection, the vessel is narrowed and you may even get some thrombus in it. So dissection is very important. So you're thinking of the vessel wall, you're thinking of things like vasculitis, dissection. Other causes might be someone who's had RT and they've got a stenosis from the RT, radiotherapy. Then think of things inside the vessel. So there may be, for example, problems with clotting. And then you can also go to the smaller vessels. So things outside like infection can also cause it. So there's a big list. So have some systematic way of going through the list, and you'll be surprised that you already know the major causes and also some of the less common ones. Okay, so here's the list. So atherosclerosis with an acute plaque rupture and thrombus, this is the large vessel. Small vessel disease, diabetes and hypertension. Embolism could be cardiac or carotid. Oh, we forgot to mention, in young people, it can occasionally be from a DVT. Now, this is rare. You shouldn't mention it really as one of your first ones, but particularly a young person who has stroke, a young person shouldn't have number 1 or number 2. And so don't forget that if you've got, for example, a patent foramen ovale or something, then a DVT in the leg would normally go up into the lungs. It would be captured by the lungs. The lungs are a net. They capture the thrombi. Do not allow them to get through into the arterial side, if you like. But if you've got a patent foramen ovale, then it can cross across and can go up into the cerebral arteries. And then other causes, vasculitis. We talked about dissection, Venous sinus thrombosis, this is usually sagittal, and some primary hematological conditions, but there are others. And it's very useful to think about possible causes when you are looking at the scan. Okay, case one. Case one is going to be for, Alvin Leung, are you there?
Oh, yeah.
Oh, you're here.
Yeah.
Okay, right, good. Alvin's here. All right, Alvin. We're going to go through this one. So case one, acute onset of right-sided weakness. Describe the abnormality and give the diagnosis. So the scan looks like this. I'm going to stop. Where should we stop? It's not a... Maybe here. Let's stop there. This little thing, ignore this. So do you want to describe that one for me, Alvin?
Let me take a look.
Or you could draw around it or describe it. So
I think there is some hypodense over the left side of the brain.
good. So this is an abnormal CT with some hyperdensity in the left side of the brain. Inside or outside the brain?
Sorry?
Inside or outside?
Inside the brain.
Inside, good. Which lobes do you think are being involved?
I think it is at the more anterior part, so it should be like frontal.
Yes, good. Frontal, and maybe this one here is maybe a little bit of temporal here. Yeah, frontotemporal. Good. Grey matter, white matter, or both?
It should be grey matter.
Grey? Is it all grey?
White matter, sorry.
White matter, yeah. Is it also grey matter as well? Does it go right up to the edge?
Yes, so both.
Both, good,
Right.
good. And you can see also the basal ganglia here. Maybe it's just starting, you can just about still see it, but just starting to come in here. Good. So what do you think, any mass effect? Any mass effect?
I think not very obvious, but I think a bit.
Yeah, very good. In fact, the midline looks okay, but maybe this ventricle here looks a little bit compressed compared to that. Yep. Diagnosis?
Should be some left brain infarct, I think.
Yes, good. So this is an infarct. What do you think the cause of this infarct is?
The cause,
So it's an ischemic infarct.
yeah, ischemic.
So what do you think the cause is? We talked about those large vessel disease, small vessel ischemia, emboli. Which do you think of those three this is?
I think it is emboli or...
Could be. It's quite big, isn't it, for emboli?
Yeah.
Does anybody want to help? Or do you want to keep going? Do you want to have another?
Maybe I'll let others to...
Yeah. Does anybody want to help Alvin here? Looking at the distribution, so Alvin, you described it very good. It's very good. It is frontal and it's temporal. The other clue is there's a very, very straight cutoff between normal and abnormal. Yes, carry on. Yes, somebody wants to. I just heard another voice. Carol, yes, Carol.
Maybe it's the large vessels disease.
Yes. Which territory?
Is it the metals or?
Good, very good, good. Yeah, so this is an MCA territory infarct, yes? So it's involving the areas that are supplied by the middle cerebral. So this medial part here is supplied by the anterior cerebral, and this part out to the side is supplied by the middle cerebral. And the middle cerebral also supply anterior part of the temporal, and it can also go up into the parietal, the anterior part of the parietal lobe. So the clue is you're involving white and grey matter. Can you see here? Here's the white matter. Here's the slightly more hyperindense grey matter. So it's involving grey and white matter. Very straight cutoff. You think about it, a pathology like tumour or infection is not going to suddenly have a completely normal brain here and a straight cutoff. So as soon as you see that cutoff like that in that distribution, you know that you are dealing with an infarct. So this is an MCA territory infarct. Good. Good. So let's move on to the next one. So this one is for Wing Yi. Are you there, Wing Yi?
Yes.
Yes. Lovely. So let's go. So.
Sorry, I wonder if
yes.
Insular ribbon sign for the previous case.
Okay. Fine. We will talk about it a little bit later. I try to stay away from lots of signs, but there is. In fact, if we go down, so we could talk about it now if you like. So which one shall I show you? Probably this one. Okay. If you look at the normal side, we've got the white matter here, the periventricular white matter that's coming into the corona radiata, and then that gets condensed into the internal capsule here. You see this black V-shaped area. So anterior and posterior limb. There is also an external capsule, which is also white matter here. It's all a bit subtle, but here. Now, just going back, this V-shaped area here divides the basal ganglia. Now, basal ganglia are grey matter, so they look a little bit more hyperdense. This is the caudate. This triangle is the lentiform nucleus, and the area at the back here is the thalami. Now, in a normal patient, you can see all that. Now, hopefully you can see it now. You can see the white matter coming in with the internal capsule. You can see the external capsule. You can see the basal ganglia. When you have an infarct, although they give it all these lovely signs, all that happens is, like at the edge, you've lost the grey-white matter. You can't see, if you look here, I can see the difference between the white and the grey. You look here, you cannot differentiate it. You've lost it. But you've also lost the differentiation of the grey and the white matter in the basal ganglia. And so they talk about ribbon signs and that, but actually all you're saying is, look, I can't see this external capsule anywhere. And even the ganglion is starting to go dark. So all it is you're seeing it, the infarct is encroaching into this area. So you are starting to lose the grey, white matter differentiation. So yes, answer your question is the ribbon sign, which is supposed to be the area around the insula here, has gone. But I think rather than all these signs, ribbon signs, just think of it much more simple. You've lost the grey-white matter differentiation at that level. So let's move on. Thank you for going. So back again. So sorry, Wing Yi again. So we'll go through this. Right. So this scan looks like this. Okay. So if I'm going to go back, Wing Yi, maybe to here. Can you describe the abnormality for me? I've told you it's abnormal. So this is an abnormal CT scan. Can you describe it?
And so this is a CT scan of the brain, and this is an abnormal CT scan, and I can see a hypodense lesion over the right frontal area.
Good, yes.
And maybe also some, it does not cause any midline shift.
Yes.
Or any compression.
Yes, correct.
Also some calcifications over the choroid plexus.
Yes, very good. So going back to this that you've described here, what do you think it is?
Probably an infarct.
Infarct, very good. So this is an infarct. What territory do you think this is? MCA, ACA, PCA?
ACA.
Good. So this is So this is the bit that was spared. If we look, go back to the last scan in this patient. This bit here was spared, wasn't it? Whereas in this case, this is the ACA. So this is an ACA infarct. But the question is, do you think this is accounting for the patient's symptoms? So again, can you see the very straight line? There's not much pathology that's going to cause a straight line like that, yes? So is this causing the patient's symptoms?
The patients complained of.
Or maybe I put it another way. If I tell you this isn't causing the patient's symptoms, why? How do I know? Just looking at the scan without anything else, how would I know that this is not the cause of the patient's symptoms? What looks different? This infarct looks different to the MCA. Number one, it's in a different area, but it also looks different from another point of view. Why else is it looking different? What's different about this one compared to the other one in terms of density?
More hypodense.
Good. Is the density of similar to fluid? Similar to the CSF? Yes. Yeah. So, but the ventricular wall is still here, but this is now fluid-like. And that's telling us that this is a mature infarct. It hasn't just happened. It would have happened months or years ago. Yeah. So what happens over time, if you've damaged the brain, maybe from ischemic or even a hemorrhagic infarct, once the brain is dead, that brain tissue gets replaced by fluid. We often call it encephalomalacia. It's replaced by fluid. So it looks black rather than grey. So it's very hypodense rather than just hypodense. The second thing that happens is that dead brain shrinks. And as it shrinks, the areas around it, like the fissures or the sulci or the ventricles, expand to take up the lost space. Can you see any evidence there, Winnie, of loss of volume on that scan? Tricky. Does anybody else want to type? Does anybody think they can see any loss of volume in there?
Any widened sulci?
Yeah, I think the sulci here maybe a bit more difficult. What about the ventricles? These are the frontal bones. Do they look the same?
A little bit bigger on the right side.
Yeah, well done. In fact, it's very subtle. Often it's much more obvious than this. But can you see this one here? Looks more rounded and a bit bigger than this one. So there is some loss of volume. So this is to show, number one, this is the site of an ACA territory infarct. And number two, that it's not new, it's old because it's full of fluid and there's volume loss. Okay, good. And here we've got calcification of the pineal, choroid plexus again. Okay, good. Right, let's move on. The next case 3, is for Tom, or Chikit. Oops. This is a CT of a child with sensory loss, hemianopia. Describe the abnormality and give the diagnosis. Which other sites could be involved, and can you find the cause? So Tom, I'll just ask you the first part of that, which is describe the abnormality and give the diagnosis. Now it looks like this. Let's just go through it slowly. And Tom, I'm going to go back to this one here. Can you describe that for me?
Yes. This is a normal axial CT scan with the showing there is a hypodense lesion on the it's more prominent on the left occipital loop.
Yes.
But it also seems that there on the right occipital loop there's also a smaller area of hypodense lesion.
Very good. Is it involving the white matter, grey matter, or both? Is it going out to the edge of the lung, of the brain?
Yes, it seems to be affecting both the white and grey matter.
Very good. Well done. So what do you think the diagnosis is?
The occipital, can it be, this is a child, so can it be any kind of trauma that
Could be, but what do you think is the actual, what is this? This is the diagnosis for this? You described it very well. What's the diagnosis? It's
this is a occipital infarction.
Yes. And it's bilateral.
Yes, bilateral.
So the pathology is probably where? So this is like a PCA territory infarct, yes?
Yes.
It's bilateral. So where do you think the abnormality might be? Is it two abnormalities in both PCAs, or could it be something else?
Can it be affecting both PCA?
So it's affecting both PCAs, but do you think it's like a lesion in the right PCA and a lesion in the left PCA, or could the lesion be somewhere else? Not PCA. Which other vessel could cause that? The PCAs come off the which artery?
Basilar artery.
Yes. Yeah. So this could be basilar artery, isn't it? So if it's just one side, maybe it's PCA, but both sides makes it more likely to be basilar artery. So you're absolutely, just to go back, so this again is quite wedge-shaped. Here's this one. And it's going right out to the edge. So you can see the white and the grey matter here, and it's gone here, and it's gone here as well. And very well done. You saw there was another wedge-shaped area here, again involving the grey and the white matter. So this is the territory in the occipital lobe of the PCA. And because it's bilateral, you worry about the basilar artery. Where else might there be an infarct if it was in the basilar artery? So the basilar artery obviously can. Does anybody want to type? Where else would you find infarcts? If you've got an abnormality in the basilar artery, where else besides the occipital lobes? Where else could you find an infarct? Where else should you be looking? Anybody can type. Nobody? Okay. So you should be looking in the brainstem, yeah, the cerebellum, and sometimes the thalami as well. Can be other sites. Now, you were quite rightly, you were starting to talk about causes, and you're right. A PCA, so ACA and MCA is usually atherosclerosis with a plaque on it in older people. PCA can be atherosclerosis from a plaque, but there are other things to think of in the posterior circulation. And quite rightly, you pointed out it's a child. So a child's not likely to have atherosclerosis. So what pathologies we've already discussed would be higher on your list this time to cause to cause a basilar artery problem that's causing bilateral infarcts? What's the likely cause? Of all those pathologies we talked about, we can probably get rid of atherosclerosis. It's not small vessel disease because it's a large vessel disease. So what's left on that list that we talked about that we should think about?
Rarely, it can be a thrombus from DVT in case this child has a patent foramen.
It could be. Yeah, no, it could be. Yes, we did mention in children, so that's absolutely true. That's very rare, but yes, it could be. There's two other pathologies that we've discussed in that list, more likely.
Can it be I'm not sure whether it can be a clot from the atrial fibrillation.
Good, yeah. I think an embolus is a very good possibility, isn't it? Maybe infective endocarditis. So an embolus would be a good one. And the other one on the list, which is probably the one that we might think about almost first for this. What else was on that list? We did 3 common causes of ischemic, and then we did those other causes.
Or can it be inflammation of the artery, such as...
Could be a vasculitis, yes. Another one, anybody? Gabriel, do you want to come back in again?
Perhaps dissection?
Yes, dissection. Yeah, I'm making you the dissection king today. Dissection, yes. So remember I said before, the vertebral arteries are very vulnerable, and you can dissect up the vertebral and up the basilar and then the basilar can be narrowed and you can get thrombus. And in fact, this was trauma. Young children, if you see two boys play, they roll around on the floor, they get hold of each other's necks, they pull, you can dissect the artery quite easily. So when you grow up and you have children, don't let your young boys roll around on the floor. It's very dangerous. Okay, don't let them get hold of each other's neck and pull. So this was actually a dissection. So this is a reason. This is one of the indications that we might be doing some sort of CT angiogram urgently at night, because for the posterior cerebral circulation, this is very important. Okay, good. So I've shown you what a MCA territory infarct looks like, an ACA territory infarct, and a PCA territory infarct. So let's move on now to case 4. And Ivy, are you there, Ivy?
Yes, I'm here.
Hello, Ivy. Fine. So describe the abnormality and give the likely diagnosis. This is, I think this is one of the hardest. I need to probably change this thing. This is a very difficult scan because you need to have your eye in for what normal looks like. Maybe I'll just show you that one. Does anything look, the patient's a bit tilted, which is why the ventricles don't quite look the same size. Whenever things look a bit asymmetrical, always have a look. Maybe when the scan was done, that the patient was a little bit tilted. But there's something else on here. Ivy, can you see anything on there?
But I think the lateral ventricles looks a bit dilated.
They do. You're absolutely right. In fact, this was an older person. So this person's got some atrophy. The ventricles are a bit bigger than you'd normally expect. You're quite right. The sulci are also a bit bigger. So this is for this patient, this is how the patient is. So anything else that you can see? So they have got a little bit of atrophy probably. What else can you see? Look at the white matter around the ventricles. Does any of it look a little bit... This abnormality is quite diffuse. So the reason it's so difficult is you can't really see a lot of asymmetry between the two sides. But does that white matter look different to the white matter I've been showing you before?
I think the bilateral frontal region, the white matter looks a bit hypodense.
Very good. Well done. This is very difficult. You need to see lots of scans, but can you see this looks very much denser than the white matter here, doesn't it? And then if we go, you can see here, if we go down, although all of the white matter is a little bit more dense than we normally see. And then if I come down to here, this is down to the level of the basal ganglia again. Remember, internal capsule, this V, caudate, lentiform nucleus, and this is the thalamus. Do you see any problem with the basal ganglia? So we've got the white matter looks abnormal. What about the basal ganglia? Maybe can you see anything in the basal ganglia? Any hypodense foci in the basal ganglia?
Is it on the left thalamus?
Very good. Yes.
There's a big dot.
Yes. Can you draw, or you can't? Are you able to draw, or?
Okay.
If not, don't worry. For time, I'll just.
Is it over here?
Yes. Well done. Very good. There is something just here. Is this bit, this round area here, and maybe something very subtle in here. And you can see this dark area is also along the external capsules. So this is quite a diffuse problem involving the white matter, particularly the periventricular white matter, and the thalami. So do you know what this is? Is this large vessel ischemia? Is it emboli? Is it small vessel disease? Which of those three is most likely? Sorry.
I think the most likely would be small vessel disease.
Good. In fact, this is it. These are the patients who've got hypertension or diabetes. What we sometimes see is in the white matter, there just may be a small lacunar infarct, a small area, or sometimes it's much more diffuse like this. Plus, in the basal ganglia, we see these evidence of little infarcts. So white matter and basal ganglia is where we tend to see the abnormalities in the small vessel ischemia. And let me just go. So I'm just drawing around it here just to show you that white matter looks a bit darker than normal. And there are these little tiny infarcts in the basal ganglia. Now, the importance of this is that even a small infarct, if it's near to the internal capsule, it can cause hemiparesis on the other side. So the small vessel disease, even a small lacunar infarct, can cause a lot of damage. And then again, to show you internal capsule, anterior posterior limb, caudate head, lentiform nucleus, thalami. Case 5 is for Philip. Acute onset of right-sided weakness. Describe the abnormality and give the diagnosis. There's a lot of streak artifact. I'm sorry about that, but if we... Hello, Philip.
Hello.
Hi. So this one's a bit more tricky, like the last one that was also tricky. We're getting to the harder ones now. Let's see. Which one should I show you? I'm trying to decide. Maybe this one. Or maybe that one. Can you describe that one for me? No, that one's harder. Let me try this time. Maybe this one. Show that one.
This is an actual CT scan, and it's a very difficult one.
It is. It's very difficult, isn't it, to determine if this is normal or abnormal. So if we go back and we say, well, the patient's got right-sided hemiparesis, you'd expect an abnormality to be on which side? It's got right-sided hemiparesis. So the abnormality be on the right or the left side?
On the left side.
Good. So now you're going to look at the left side. And you're absolutely, if I tell you this patient's got an infarct, but the problem with infarcts is that very early on, first 12 hours, sometimes longer, it can be quite hard to see them on a CT scan. Very often the CT scan may be completely normal. You can't see anything. Sometimes you start to see subtle abnormalities, and the very first things you start to see is the loss of the differentiation between the grey and white matter. So we're looking on the left side. Have a look round the edge, the convexity, and see if you've lost the grey-white matter. And then remember I said don't forget the basal ganglia. Have we lost some of the anatomy of that definition in the basal ganglia? Can you look carefully and see? This is very subtle. It would not be surprising to pass this off as normal, but if you look, so look, the grey-white matter, so look out here on this side, you've got a little bit white, which is the cortex, and a little bit grey, which is the white matter. What about here? Can you see the grey and the white matter?
No, it's not very
good. And here?
No.
Here?
A bit better.
Yeah, good. So maybe can I convince you, maybe there's a line here? And this is all dark. And then this, we start to get it back again, but this is still dark. What about the basal ganglia? Can you see the internal capsule and the caudate head? Caudate head, yes, but internal capsule?
No.
It's all blurry, very good. And then if you look at the thalamus, here's the external capsule, the posterior limb of the internal, but no. And if I look at the lentiform nucleus here, we've got a little bit of the external. Is it there?
It's not very well.
Absolutely. So we've got blurring. And what territory is that in?
The middle would be the
Yes, it's the middle cerebral artery. Yes, good. So this is actually a very extensive infarct. It's an MCA territory infarct, but it's very early, which is why it's hard to see it. So if you're looking for infarct, you can't see one. Number one, go back and look at those small vessel diseases, those little tiny locular infarcts, particularly if they're near the basal ganglia and the internal capsule. If you still don't see anything, go back and sit back and have a look. Could there be a very early infarct? And if they are a large vessel territory, you might just start to see this blurring. Philip, what test would you do next? What's the better test for picking up early infarcts in CT? In fact, let me ask you, let me open this up. Dominic, are you there? What's the better test for picking up an early infarct? Dominic?
Hi.
Hello. I shall just scatter some questions around and see which imaging modality can show an infarct a bit earlier than CT. Anybody want to help Dominic? Which imaging modality?
MRI.
Good, absolutely, MRI. And so when you're on the ward, you'll hear the doctor ask with MRI. And now on MRI, you can pick it up already earlier on T1 and particularly T2 weighted sequences. But what's the one sequence you'll hear the doctors requesting that's probably the best sequence for picking up the early infarcts? Or not the best, but the one that we use most commonly. Anybody want me to answer that? Carol, which sequence do we use?
It's just a diffusion weighted.
Very good, well done. Diffusion weighted imaging. So let's move on a little bit and just quickly talk about diffusion. You've all heard about diffusion weighted imaging, yes? You heard the doctor say DWI. Do you know what diffusion weighted imaging is? Okay, shall I explain it very simply? MRI can be divided into two. One set of sequences, the first set at molecular level, and diffusion weighted imaging is one of those. And what it does is it looks at the movement of water molecules in tissues. So usually the water molecules can move around a little bit, or they might be a bit more restricted. So if you think about it in CSF, the water molecules can go wherever they like. Whereas in the brain, they're going to be a little bit more restricted. They can't go where they like. Now, what tends to happen in an acute infarct, so one that's just happened, I like to think of it that the water molecules are moving a little bit in the brain, and then suddenly you get an infarct and the brain is stunned. And those water molecules stop moving. A little bit later on, it will start to move again, but in the acute phase, they stop moving. And we call that restricted diffusion. The diffusion of the water molecules is restricted. Now, what does that look like on imaging? Well, for the imaging, for DWI, there are actually two sets of images you need to look at. One is actually the DWI source image itself. And if you ever look at them, you'll find there are many of these. And they're all done at different, we call them B values, different strength gradients. But we are looking at the highest. So you may find a B0, a B500, a B800, a B1000. Look at the high one, either 1000 or 800. Now on that image, you can see the CSF. So, as we said, the water molecules are not restricted in the CSF, so it looks black. Whereas restricted diffusion, such as in an acute infarct, will be the opposite. It will be white. So look at the DWI at a high B value, and the acute infarct will have restricted diffusion, which looks white. Now, what we do is we put all the information from the different DWI images together, and we come up with something called an ADC map. And on the ADC map, it's the opposite. You can see that the looks white. So something with restricted diffusion on an ADC map will be dark. And you need both of these. I can't go into the reasons why, but if you look on your images and you see it's bright on the high B value and it's dark on the ADC map, that shows you it's an acute infarct. Okay, does anybody have any questions about ischemic stroke? Anybody questions about ischemic stroke? Okay, just a couple of other things to mention then. We talked about the large vessel disease. One of the reasons it's important is that we are now doing thrombolysis. And so when you're on the ward, find out the indications for thrombolysis. Just as a general principle, for thrombolysis to work, you want to do it as early as possible. So you're looking for a very acute infarct. If you leave it later, then the problem is that it may not respond so well. And you've got the added risk that you may get some hemorrhage from the thrombolysis. So you're looking for the very early infarcts. Obviously, when you look at your scan, if any patients had any hemorrhage on the scan, they can't have thrombolysis either. And that's important because sometimes these infarcts, usually later on though, can undergo hemorrhagic transformation. So make sure there's no hemorrhage on the scan. Okay. And then vasculitis. We mentioned SLE earlier. That's probably our commonest vasculitis we see. That one often causes peripheral infarcts, and they can be extremely difficult to see on CT. And so we do a lot more MRI in that condition because it can pick up the infarcts a lot easier. Okay. No questions about ischemia? Is that it? Yes.
Can I ask a question? So
yes, is that Philip?
Just now,
yes.
Yeah.
Put your camera on. Is it?
So just now.
Yes.
So the case now, so there was so at very early stages of an infarction, we might only see
nothing. Yes. I think you're frozen there. Hello, you. Okay. Can you hear? I think you've frozen. Just maybe I just quickly supplement that. Well, basically, to be very honest, the timing in which you give the thrombolysis is based on the onset of symptoms. So if the patient's already come in too late, based on the onset of symptoms, it's not really so much based on the CT. So it's got to be within a certain time frame. And then you're using your CT to try to see if it looks as if it's going to be a large vessel problem that's going to benefit from the thrombolysis. This is quite a complicated area. It's changing all the time, but it is an area that when you're on the wards, please pay attention, follow up the patients, see when they're going to give the treatment, because it is very important. I may just, for time, just need to move on quickly if that's okay. I'm just going to move on to, okay, next question. Hemorrhagic stroke. Now, of course, as we just mentioned, ischemic stroke, 24, 48 hours later, it can undergo some hemorrhage. Just like contusion, you damage the brain. Any fragile, damaged brain can bleed into it. But there are primary causes of hemorrhage which present as stroke. And so I just have a quick question for, who shall I ask? Natalie. Natalie, are you there? I forgot to ask right at the beginning, Natalie. Yes. What is a stroke? What is a stroke? How do you define stroke?
I think a stroke is the impairment of blood supply to the brain.
It is, but it's a bit more because that could be a TIA or a. It's an acute neurological deficit. So you're going to have a neurological deficit. So not just like loss of consciousness with a subarachnoid hemorrhage. It's usually a focal neurological deficit as a result of a cerebrovascular incident. So that would be the cause of a stroke. So, okay, let's move on. In fact, for everybody, can you start typing? Everybody give me 3 common causes of hemorrhagic stroke. 3 common causes. Everything's a 3. 3 common causes of hemorrhagic stroke. Hypertension, very good. Absolutely the most important. Yes. Anything else? Anticoagulants, yes, that's probably another. Warfarin, very good. Anything else? Good. AV foul formation, yeah, well done. So, it can be because there's hemorrhage into an underlying lesion, such as an AVM, occasionally a tumor. Subarachnoid hemorrhage doesn't really usually cause focal neurological deficit. It may cause global. You may lose consciousness, and you obviously can get headaches. But focal is not so common unless the blood is ruptured into the brain itself. So usually because it's in the subarachnoid space, it's more headache and loss of consciousness. So those would be the 3 main causes: hypertension, bleeding because of someone on anticoagulants like warfarin, or bleeding into an underlying abnormality like an AVM or tumor. Can you type some more causes? List 4 other causes. Nobody? Trauma. I suppose trauma, but usually trauma comes along as trauma, doesn't it, rather than stroke. I guess one of the important things for trauma we've discussed already is you can damage, for example, your vertebral artery, and that can dissect. And then that may cause an infarct, which does present as stroke. Anything else? Okay, let's just quickly show you so we've got hypertension, hemorrhage into an underlying lesion, anticoagulant or bleeding disorder. Trauma we've got here, as I said, usually maybe through the dissection or other route. We've mentioned the aneurysm, although usually it doesn't cause a focal neurological deficit. Other ones are things like amyloid angiopathy. This is not so common. It's elderly, tends to be peripheral. The venous thrombosis, like sagittal venous thrombosis, and actually the emboli, have also an increased risk to bleed. But I think the main ones are these 3. As I told you, everything is 3. These are the 3 main causes. So bear this in mind when we go through the questions. So case number 6 is for Chiam. I think you're there. CT of a patient with acute onset of headache, vomiting and fits. Describe the abnormality and give the diagnosis. So maybe I just go back to here. Could you describe that one for me? Yes. Very good. Likely cause? Yes, but what would be the underlying cause? So absolutely, this would be a hemorrhagic stroke. Very good. So this patient obviously can't have thrombolysis. But what do you think the most likely cause for the hemorrhage is? We had a list of 3 possible causes. If I told you the patient's on warfarin, has no anticoagulant problem, what do you think the most likely cause is? Yes, or even younger patients with hypertension. Good. So hypertension. So the patient did have hypertension, but even without the history of hypertension, why would you suggest this could be a hypertensive hemorrhage? Because you're right, this was hypertensive. What's the other clue on here? This is a hypertensive hemorrhage. You've described, okay. What I'm getting at is actually it's a site. So you described it beautifully. If you put your cursor in the middle, then on the opposite side, it would be about here. And quite rightly, you called this the lentiform nucleus. So internal capsule, this V, caudate, thalamus, lentiform nucleus. And hypertensive hemorrhages have a tendency to occur in the lentiform nucleus, particularly the outer part, the putamen, which is why it's sometimes called putamen hemorrhages. Other sites for hypertensive hemorrhage include the thalami and occasionally the brainstem. So if a patient comes along, they're hypertensive, they've got a hemorrhage here, your diagnosis is hypertensive hemorrhage. Full stop, finished. If, however, this hemorrhage was, say, in the frontal lobe, maybe it's a young person in the frontal lobe. I'll open this up maybe to, who should we ask this up to? James, are you there, James? If this hemorrhage was somewhere else, what do you think a possible cause would be?
Maybe some aneurysm.
Yeah, as you said, aneurysms don't often rupture into the brain. They tend to be more subarachnoid.
How about some maybe AVM?
Good, yes. So we would worry about an AVM or maybe a bleed into another tumor. Very good. So if I just, where have I got you? If I just go back to Chihing again, you're still there? Yes. What test would we do next? If the hemorrhage is somewhere else and we're worried about AVM or a tumor, what test would we do next? We could. What else could we do? Yes. Good. Yes. So what we tend to do here is we often do an MRI next because the MRI will often give you a clue, even on the anatomical images, whether there looks as if there might be a tumor underneath. Sometimes we see it looks like a bag of worms, serpiginous structures, which may suggest it's an AVM. And then we can do an MRA, an MR angiogram at the same time. Now, one of the advantages, let me go back. MR angiogram is probably not as good as doing a DSA or a CTA, but it's quite good. And one of the advantages, you don't even have to give contrast. You can do it without contrast, although you do get slightly better images with contrast. So what I'm saying is that the MR, if you do MR and you also combine it with an MRA, that's a very good idea of trying to see whether there could be an underlying abnormality. Now, if it's completely negative, you may not have excluded a small tumor or a small AVM. And sometimes for the very small AVMs, you need DSA. DSA is the digital subtraction angiogram, where this is the invasive one. A catheter in the artery, you push the catheter out, inject the dye, and take the pictures. But we try to leave that really to the last investigation because it's invasive. We try to solve the problem without doing that at the beginning. Okay, thank you. So did I forget, Hi, Law, did I forget you? Have I just gone over, did I skip you?
Yes.
I did. Sorry about that. I haven't forgotten you. Okay, so I will show you the next one. Patient with severe occipital headache, loss of consciousness. Describe the... actually, before I do that, let's get everybody typing. See if you're... So I've just described different ways of doing angiograms. Can you just type for me 4 imaging modalities to look at blood vessels? What are the 4 imaging modalities that look at blood vessels? Everybody can type. Then I'll come back to you in a moment. Chihai, can everybody type for me? 4 imaging modalities. You can type 1, type 2, just type anything. So CT angiogram, good. So CT angiogram, very non-invasive. We just put the contrast into the veins in the neck, in the arm. Good. MR, we've just mentioned, you can do that again with an intravenous contrast injection or none. DSA is the one, as we just said, that involves the catheter, so it's much more invasive. And well done, Gabriel. Ultrasound is the third one. This is really to look for the blood vessels in the neck. Okay, so let's go back then to Shihai. We'll just go back to you now, and let's look at this one. Severe occipital headache, loss of consciousness, describe the abnormality. And then we will throw this open to everybody else. Okay, so it looks like this. I might stop there. Could you describe that one for me?
I think, so this is an abnormal CT scan. Do you have a
camera? Do you have your camera there? Is it?
Yes.
Yes, I like this. Yes.
So
yes, carry on. Sorry for interrupting. Carry on, yes.
And I think there is some hyperdense lesion in the basal system area.
Very good. Yes. Anywhere else other than the basal systems?
Maybe also in the frontal area.
Yes, a little bit, yes. So we're looking here. So what do you think the diagnosis is?
Subarachnoid hemorrhage.
Good. Well done. So this is a patient with an acute subarachnoid hemorrhage. So if we look, we've got the brain stem here. This is the midbrain. And around the edge, there should be black CSF. Instead, there's white because the blood has leaked into the CSF. Do you know, what is this area called here? Tammy, do you know what that area is there?
It's in the circle of Willis.
Good. It's the circle. This is where the circle of Willis is. So this is actually the suprasellar system. And so we've got blood in there. And it often looks, to me, it often looks like the body. So you've often got like a little head here. You've got some arms going off and the legs coming down here. So and this is the suprasellar system. And here the blood is also tracking along the falx. It's tracking along the course of the middle cerebral arteries out to the, what would be here? What is this? From the shape. What is that?
Is it the Sylvian fissure?
This is the Sylvian fissure. Remember, they look like these vertical slits. So there's these Sylvian fissure. You can also see blood is going along the falx. You can see that there's blood in the sulci. So this is blood everywhere. Now, again, just if you're in a viva in an exam and you see something and you know what it is, you can try and keep talking. So you could say, oh, I can see blood. It's in the basal systems. It's in the suprasellar system around the circle of Willis. It's tracking out along the middle cerebral arteries. It's going into the Sylvian fissures. Keep talking, because then your examiner can't ask you a question that you don't know the answer to. So you keep talk. And you might go on to say this is a subarachnoid hemorrhage. Then you could go on and talk about the causes of a subarachnoid hemorrhage. So keep talking when you get onto the subject you know about. So tell me, what are the 3 common causes of subarachnoid hemorrhage? Everything's 3. What's the 3 common causes?
Hypertension.
A subarachnoid hemorrhage?
Rupture aneurysm.
Good. Berry aneurysm would be number 1. Yes. What else?
Trauma.
Trauma. Good. Yes. Third one?
And also maybe AVM.
Yes, probably an AVM. Very good. So 3 common causes of everything. When you go to your finals, have 3 common causes for everything. That's going to make you a safe doctor. Everything after that will be the less common things. Okay, good. So just moving on. So you can see where all this should normally be black CSF and it's being replaced by white blood. I have a question. I'll just throw it open to Daisy. Daisy, are you there? What are what investigation do we do next in Prince of Wales? Daisy, are you there?
Yes, hello.
Hello. Hello. What investigation do we do next? We've done a CT, we found this. What do we do next? What imaging modality do we do next?
Maybe do a MR angiogram to look at any aneurysm.
You're on the right track, but it's not MR.
DSA?
No, that's very invasive. Keep going, you're nearly there, not many left.
CT angiogram.
Yes, CT angiogram. Okay, so again, in this hospital, we do CT angiogram next. And so if you're in your Viva and they ask about this, your answer to that will be, when I was on the ward, we would send our patients for a CT angiogram. So show, why do we do CTA? Derek, are you there? Why do we do CTA? What are we trying to achieve by doing a CTA? Derek?
Hi.
Hello.
I would like to localize the lesion site.
Yes.
And then to...
We've got two goals really when we're doing it. What are those goals?
For the imaging for the diagnosis.
Yes. Number one is diagnosis. So is this an aneurysm or is it an AVM? What is it? Absolute diagnosis. And the second reason?
To localize the lesion.
Because?
Because it is for further planning, for example, for surgical coiling.
Excellent.
Or DSA.
Excellent. So number one is to make the diagnosis. So you do the CTA, and we do CT because actually CT is a bit better than MR. And of course it's available. You can easily get a CTA, and the images are very beautiful, and you can see even very small aneurysms. So number one is to make the diagnosis. Yes, this is a ruptured aneurysm. But secondly, it is to work out, just as you said, where is it? How big is it? What's the neck size? What vessels are close to it? Because that allows the interventional radiologist or the neurosurgeon to plan the treatment. So the DSA, when you put the catheter up, is then not used for diagnosis. It's used to put the coils in at that time. And it's very good for the surgeon or the radiologist to know what they're dealing with, because they can then consent the patient with the possible risks and they're prepared. So that's why we do the CTA, to prepare for the next step of the interventional treatment. So very good. Okay, moving on. Let me just quickly move back. Who have I got? Marcus, are you there? Marcus? What are the three complications of subarachnoid hemorrhage? So in the next couple of days, patient becomes unwell again. What are the complications? Maybe you can just give me one. Give me one complication.
Increased intracranial pressure.
Sort of. What? From what? I mean. You're on the right track. So what's
hydrocephalus.
Absolutely, hydrocephalus. Very good. Hydrocephalus one. Michelle, give me another one.
Rebleed.
Rebleed. Very good. So rebleed. Yep. And who else shall I ask? Fung Ching, give me a third one.
Hyponatremia.
It's not so common. I'm thinking of something a bit more common.
Systemic hypertension.
Later on, you can get hydrocephalus because of problem with absorption. But in the acute phase,
cerebral edema.
Sort of from. So vasospasm is what I'm getting at. Yes. The vasospasm can go on to cause problems. Good. Right. Moving on. I got a question for. Let me see. Avery, are you there, Avery?
Yes.
Can the CT scan be normal in a patient with subarachnoid hemorrhage?
I think it's possible.
It's possible, yes. Yes. Okay, so it's possible for two reasons. Number one, maybe the hemorrhage is tiny. So the ones I'm showing you are big, but sometimes the hemorrhage is very small. So it's easy to miss it. And the second thing is that over time, the blood will be reabsorbed and you may not see it. What test might still be positive, even if the CT scan has become negative?
I think an MRI may be better.
Okay, it's true. We don't tend to use it for that reason, but it can be, yes. Anything else? And what I'm getting at is a lumbar puncture may still show some xanthochromia in it to prove that there's been a previous subarachnoid hemorrhage. But a normal scan does not exclude a subarachnoid hemorrhage. Okay, I think that's it for... I think that's it for this. So I think we're done here. Anybody got any questions about stroke? So for stroke, you need to decide whether, is it normal or abnormal? If it's abnormal, does it look like a ischemic stroke or a hemorrhagic stroke? I put subarachnoid hemorrhage in here. It doesn't tend to present as stroke, but it's really in those cerebrovascular abnormalities, so that's why it's here. Then you go back, and if it's an ischemic stroke or a hemorrhagic stroke, try and work out the possible causes as well. If you know the underlying cause, you know what you're already trying to look for, and it does help when you're looking at these scans. And be aware that for the ischemic strokes, the CT can be normal, and MRI, like using DWI, can pick it up much earlier. Okay. Any questions about stroke? Any questions? None? Anybody want to unmute and ask a question?
Sorry, for the reason why we do CTA over MRA, is it really like a matter of time because MRA would take a long time?
It is. So to be honest, the main reason is CTA is actually better than MRA. Just the anatomy and the resolution and the less artifacts, CTA is actually probably better. The second thing is that it's available. You know, in the middle of the night, you may not get a MR, but you would be able to get a CT. And very often the patient may still be on the scanner, and then you can inject the contrast, and then you can do it. So it's logistics. It's easier to get, and the second thing is it's actually better than an MRA.
Okay, thank you.
Again, different places do different things. So again, that's why it's very important. Hopefully by the time you come to the exams, you will be having vivas, proper vivas again. And they can ask you questions. And if you can answer from personal experience on the ward, that's much more impressive. It also means that maybe if they don't agree, particularly an external examiner may not agree with what you're saying, but then he's not going to criticize you because you said that's what our practice is at PWH. So there are lots of reasons why it's very good to talk from personal experience and to get that experience on the ward, because it makes it much more easy to remember. Right. Shall we take a break? Let's come back just before 12 o'clock, a couple of minutes just before 12, because the next tutorial is really miscellaneous tumours, infections, and we will quickly go through that. And then if there's time at the end, I've got a few more questions I can show you as a quiz if you want to stay on to see those. So let's come back just before 12 o'clock. Okay, right.
Recording stopped.
This topic is tumor, infection, and miscellaneous. Let's just start with a few general points. Until now, we've been talking about CT, because obviously it's very important for trauma and for strokes. I just want to quickly introduce a few terms for MRI. Now, of course, MRI, we don't talk about density, we talk about signal intensity, but it's the same, it's white, it's hyper intense, it's the same as the brain ISO, and darker than the brain, it's hypo intense. I just want to mention though briefly the sequences, because I think MR sequences can be very complicated. I think part of that is because there are different manufacturers of MRI scanners, and they will give the same sequence a different name. So somebody might call it a turbo spin echo, and another manufacturer will call it a fast spin echo. And that can make things very complicated. But I think that when it comes to the brain, there are three basic sequences: the T2, the T1, and the T1 post-contrast. The T2 looks very different to a CT scan. If you look at it, the fluid is bright. The T1 looks a little bit like a CT scan, but the clues are the anatomy is much better, a lot of greater detail on the CT. The other clue is look at the fat. The fat on MRI, whether it's T1 or T2 here, is bright. Whereas remember on the CT scan, that fat is black. So look at the fat. That will also help tell you that we're dealing with MRI. But equally, just like on a CT scan, you do a pre and a post-contrast scan. On MRI, it's a T1 pre and a T1 post. So you can see here there's a tumor and it's enhancing. And all this darker area around the edge here is the edema. So we've got a tumor and we've got edema. So those are the main three sequences: T2, T1, T1 post-contrast. There are a couple of others, though, for the brain that's worth thinking about. The first one is we have a T2 weighted image here. The CSF is bright. The problem with this is that your eyes are looking at all of the bright signal in the ventricles and around the cell side. And it can be so busy that it's easy for your brain and your eyes not to register the pathology, which is often also hyperdense. And so to do that in the brain, we do something called a flare sequence. And this is where we suppress the signal from the CSF. So it's no longer white here, no longer white around the edge. And what that does, it allows the pathology, which is already there. It was there before, but it stands out and it's much easier to see it. The problem with this, of course, is you look at that and you think, oh, that signal is dark, maybe it's a T1. So look very carefully. The clue is you've got all these high signal abnormalities and the fact that it will probably say on the scan it's a T2 flare. There's one other sequence to mention. That's the one that we've already seen, and that's the susceptibility weighted sequence. What that does is any little areas of hemorrhage that might be difficult to see on your standard sequence, it magnifies them and makes it easier. So if you look at this T2 weighted sequence, I certainly wouldn't be able to see an abnormality on here. I'm sure you can't either. But if you go to the susceptibility weighted sequence, there's that little black dot, maybe another one next to it, corresponding to this area. So this shows you that there's been a small micro hemorrhage at that site. So these are the sort of sequences that you will see quite often. And then another one, which we've already mentioned before, is DWI. That can also be used for other things, not just for stroke. Now, if we move on, also for MR, as we've mentioned, you can do MR angiography. So here you're looking at the blood vessels, the posterior circulation, the anterior. And one of the advantages is that we can do it without contrast. So that's a very easy, quick way of doing it. So we often may add this to a scan. We can give contrast. Again, the contrast is just into the arm, so non-invasive. And the contrast scan will give you a little bit more detail. There are non-anatomical sequences. I've just mentioned diffusion-weighted imaging. There are some others. There are ones that can look at the contrast as it goes through, rapidly scanning. There's something called magnetic resonance spectroscopy, where you can sample metabolites inside. And functional MR is a sort of term that we tend to use in the brain for looking at activation of sites. So if you are doing an activity, moving your hand, whatever, that area of the brain can light up because of changes in blood flow, and that's called functional MR. But as I said, the ones that we're going to be concentrating, we might mention a little bit about diffusion, but the main ones are these ones here and the flare. Okay. So that's a little bit about MRI. Does anybody have any questions about MRI before I carry on? Anybody have any questions? You can unmute or no? Okay. Right, in that case, let's start with some tumours. Can you all start typing for me? Give me, or actually, no, I'll tell you what, I will ask. Let's ask some questions. I just need one answer from each of you. So let's go to Grace. Can you give me one common tumour that occurs inside the brain?
Astrocytoma.
Good. So good. So if we put it as a big group, glial tumours, so astrocytoma, it could be oligodendroglioma, it could be glioblastoma multiforme, the glial tissues are one big group. Very good. Ivy, give me another big group of tumours that occur inside the brain, intraaxial. So in the brain, in the parietal lobe, in the temporal lobe, in the frontal lobe.
It could be ependymoma.
Yes, I sort of put that under the sort of the glial type tissues. What about another big group of tumours that are different to the glial tumours? The most important ones, the ones we see most often.
Is it hemangioblastoma?
Oh, that's another one. That's a rare one, commoner than that. Anybody else help Ivy out? What's a common group of tumours that can be found in the brain?
Metastasis.
Yeah, metastases. Very good, metastases. And Alvin, give me one more group. Not so common. These ones are quite rare.
Let's see. Astrocytoma?
Yeah, again, I put that under the glial. Actually, what I'm getting at is lymphoma. So actually anywhere in the body, particularly if you see multiple lesions, metastases and lymphoma are two very good diagnoses to have up your sleeves because they can occur anywhere. Good. So those are the three big groups, will be the glial tissues, the metastases, and the lymphomas. Okay, so with them, let's move on. So case one. This one is for, don't worry, Avery, Natalie, and Derek, I haven't forgotten you, but I'm going to start with Daisy. Daisy, can you answer this one? So there's a plain and a contrast enhanced CT of a patient with headaches and they have breast cancer. I want you to describe the abnormalities and give the most likely diagnosis. And then if this patient with headaches and fits has no known cancer or was immunocompromised, would you suggest an alternate diagnosis? I may open that one to everybody. So Daisy, if you could maybe try and answer the first question here. Okay, so the scan looks like this is before contrast, this is after contrast. Maybe I will go to here. Daisy, can you describe that one for me, please? Daisy, are you there?
Yes.
Yes. Hello, Daisy. Hi. Can you describe
this
that?
is an abnormal SU MRI CT scan.
Yeah. Again, the clue. If you have a look at the fat underneath the scalp. It's black. Yeah. So the black means it's CT.
Showing a lesion at the left side of the frontal lobe, which is a hyperdense lesion with a hypodense center.
Yeah, can you draw around it? Are you able to draw? No, if not, don't worry.
I don't know how to draw.
No problem. Okay, so you're describing this one here, yes?
Yes.
Yes, good. So there is so can you see how we were talking earlier, some lesions you just can't see on this on the scan until you give the contrast. So you wouldn't know that this is here until you gave the contrast. So there's a rim enhancing lesion here. Do you see anything else on this scan? Do you see a second lesion? Is there anywhere else that's contrast enhancing?
Is it also on the left side around the Sylvian fissure?
So, frontal, you mean this one here? Is it?
Yes.
Yes, good. So this is in the frontal lobe. Good. There's something else. Can you look at the white matter? Do you see how dense the white matter is? And it looks quite fat. This is actually edema. So we can already see the edema before contrast. There's something funny going on here. There's edema. But before contrast, we don't know why. After contrast, we can see the rim enhancing lesions. In view of the history I've given you, what's the most likely diagnosis?
With the breast cancer history, and since there is multiple lesion, it probably would be metastasis.
Very good.
Breast tumor.
Good. This is absolutely right. Metastases. Let's just quickly go back to here. Does anybody see an abnormality on here? This is open to everybody. If you see anything, you could draw around it. Can anybody draw around an abnormality there? Nobody there? No? Okay. Just for time. There's another rim enhancing lesion here. Yes, well done. Well done. Very good. Yes. Another one there. Good. We've seen two here. Does anybody see an abnormality on here? You can type yes or no. Everybody can type. Is there another? There's edema still, but does anybody see any more enhancing nodules or rim enhancing lesions? Can you all type yes or no? Yes or no? Can anybody see a rim enhancing lesion on here? Can you all type yes or no? No. Okay. Well done, Carol. I agree. No. Very good. Moving down. Nothing on there. Anybody see anything on here besides the edema? Yes or no? Now this is going to be brave. Yes or no? Tom, yes or no? Stephanie, yes or no? Are you there? Yes or no? Yes. Oh, okay. Where? Yes. Whereabouts? Does anybody want to, who said yes, wants to tell me where? Carol, here. Oh, okay. That's good. It's difficult on this. That's probably one of the branches of the anterior cerebral artery. Down here, probably okay. So I think the answer on this one is no, no other lesions. Okay, let's keep going down. Anybody see anything on here? Yes or no? Yes, okay. Philip, do you want to draw around? Or Alvin, do you want to draw around where you see the abnormality? Philip or Alvin, do you want to draw? Can either of you draw? No? Okay, do you want to type? Where is it? Do you want to type? Philip and Alvin, do you want to type? Where do you see the abnormality? Up. Okay, yes. Very good. So there's a lesion. Very good. So there's another rim enhancing lesion here. Now this one is actually in the cerebellum. Here is the tentorium, and this is the top of the cerebellar hemisphere. Very good. So this patient's got multiple lesions, and maybe even another one down here. So this was metastases. Who can I ask? Let's see. Let's ask Avery. Are you there, Avery?
Yes.
If this patient history was, say it was a man with HIV or who didn't have a cancer, could it be anything else?
For HIV, then he is immunocompromised, and maybe I will think about some infections.
Very good. Yeah. So this could be there are infections, toxoplasmosis, TB. They can look exactly the same. And so the message here is that on imaging, sometimes we can be very certain MCA territory infarct is probably going to be an MCA territory infarct, no matter what you tell me. But something like this is much more non-specific, and there may be a very, very big list of possible causes. And what we write on the report will be very much guided by what you write in the request. So we may give you a different report if you give us a different clinical history. So the clinical history is really, really important in cases like this. Okay, let's move on to the next case. Case 2, this is for Derek. Derek, are you there?
Yes.
Hello, Derek. Right, so a patient MR this time, headaches and fits. Describe the abnormality and give us likely diagnosis. And then I'm going to ask you whether it looks aggressive or non-aggressive. And so I'll come back to that question in a minute. So here we go. So this is, which sequence I've said it, and it's T2. So T2, you can see the high signal in the CSF. I'm going to go through the T2 first. This is quite complicated. I think my first question is, do you know what this is here, this T2 area? What do you think this is?
I think it's the temporal lobe.
Yeah, it's just coming above it as well. But what do you think the pathology is causing this high T2 signal intensity? From the shape and where it's going, what does it look like?
It looks like some kind of edema.
Good, very good. So this looks more like edema. They describe it as fingers in a glove. So it looks as if it's fluid and it's extending out. So edema. And then as we go down, we can see more edema. You're right, temporal lobe, coming back into the occipital lobe. A lot in the temporal lobe here. And now we're coming into something else as well as the edema. There's something here. Can you describe this?
I think there is a mass.
Yes, there's a mass. Very good. And the mass has got two components to it, hasn't it? It's got a rim and a center. Can you describe the rim in terms of intensity and the center in terms of intensity?
The rim is hypo-intense and the center is hyper-intense.
Good. So what do you think the center is made of?
So the center is made of fluid.
Yes, good. So it's a bit like the edema outside, isn't it? And this is probably the more solid tissue. So let's now go to the contrast scan. So this is before contrast. This is after. This is a coronal image. So my question is this area enhancing? So we've got the edema around the edge, but is there any enhancement?
Yes.
Yes, very good. So here you can see not very much, and here you can see all of this is enhancing. Good. So let's go back to the axial, and it looks a little bit like this. So we've got an enhancing lesion. The solid bit around the edge is enhancing. There's another very solid area here. Why is the center not enhancing?
Because it's not vascularized, so the contrast cannot get into.
Very good. So this is the necrotic bit. Now, if I'm to tell you that this is a tumor, this tumor is in your brain, do you think this looks very, very worrying or not so worrying? I mean, obviously any tumor is a worry, but would you be particularly worried about this one?
I think it's very...
You worry. Okay, you don't want this one in your brain. I agree. What are the features that are telling you that this looks nasty?
I think the center necrosis is the most worrying.
Good, absolutely, because it means it's growing rapidly and it can't sustain a blood supply because it's growing so quickly. Good. What else on this tells you it's quite aggressive?
And it is contrast enhancing.
Good, very good. So in general, outside the brain is different, but tumours inside the brain that are contrast enhancing are usually more aggressive. Yes. Anything else?
Also, there is edema around the tumor.
Good. A lot of edema, and it was causing some mass effect, wasn't it, as well? If you look, it's really compressing everything. So edema, mass effect, contrast enhancement, and necrosis, they're all signs. Do you know what this tumour probably is? It's a solitary tumour, so it doesn't look like metastases. Solitary tumour, it's probably a... Yes, in fact, this was a glioblastoma multiforme. This is a very nasty one. Now, just to move on, let's ask a question. Sorry. So well done. Just moving. This shows you the mask. Okay. Just to go back, I think I had another question. Let me just, sorry. Yes. So the next question was, maybe I'll throw this open to Philip. Are you there, Philip? If this is not a tumour, what else could it be? What else causes rim-enhancing lesions anywhere in the body, in the brain, in the lung, in the liver?
Abscess.
Abscess, very good. Do you know, so you may have, for example, the patients come in, they've got some focal neurological deficits. Maybe you've looked inside and they've got papilledema, and you're worried that they could have a tumour or an abscess. You've done a CT. You've shown rim-enhancing lesion. You've shown lots of edema. And now your question is this a tumour or is it an abscess? So you're going to send the patient for MRI because that's the next step to be able to tell. And on the MRI, we're going to do those sequences we've seen, T1, T2, T1 post-contrast. But can you think of any other sequences that we could do that might help us distinguish abscess from tumour?
Diffusion.
Very good. Diffusion, yes.
Weighted sequence.
So a diffusion weighted sequence, and anything else right at the beginning when I showed you MRI. Any other sequences? Nope. So I was getting at MRS, magnetic resonance spectroscopy. So let's just quickly. So if you look at this lesion, this solid bit would not be like an abscess. So I think we already know, but this enhancing lesion, we can do DWI as you suggested. What happens with DWI? Do you know why DWI might work? Why could DWI work?
Because DWI looks at the water movement.
Yes, yes.
And
why might it be different in the necrotic part of an abscess compared to the necrotic part of a tumour? Can you guess?
Because in the necrotic part, there would probably be restriction in the movement.
If it was tumour or abscess?
If it was a tumor?
Yes, it's a good guess. It's a difficult one, yeah. Actually, to be very honest, often we can't tell because there's so much overlap. But the concept behind it is that if it's an abscess and it's full of thick pus, you know, pus can be very viscous. The thick pus stops the water moving, so it looks restricted. Whereas if it's a tumour, that's dead tissue, it's died, it's got edema, it's dead tissue, that one is less restricted. So it's thought that it would be more restricted if it's an abscess. Doesn't always work, but that's the idea. The other thing we can do is MR spectroscopy. So we'll do the scan. We can then, on the scanner, we can place a little box on our control panel and we can sample what's inside it, and that gives us a spectrum. And abscesses sometimes have specific metabolites at certain places, which may also help us. So all I need you to be aware is that, you know, for an abscess and a tumor, it can be difficult, and you do need MRI. We often do extra sequences like DWI and MRS to try to help us distinguish, because it's not always very easy. Good. Okay, case number 3. Oh no, sorry. Just get right. Everybody get typing. Give me 3 common causes of tumors that occur outside the brain. Can everybody start typing? 3 common tumors outside the brain. Meningioma. Very good, Philip. Yes. Any more? Outside the brain? Yes, so the pituitary adenoma is outside the brain. Yes, that's a good one. So the pineal tumor would be similar, and it's not actually in the substance of the brain, it's outside. Any other tumors? Posterior fossa? What tumors would we think about in the posterior fossa? Good. Vestibular schwannomas. So remember, the cranial nerves are mainly in the posterior fossa. So if you have a tumor along the cranial nerves as they're coming out of the brainstem, then you may also see that that's an extraaxial tumor. Very good. So it's very different. I think the commonest ones would be meningioma, would be the nerve sheath tumors. And then you've got this extra one, which could be pituitary or pineal. And maybe it's even something in the bone, like a metastasis that's then bulging in. Okay. Right, let's go to Natalie. Are you there, Natalie? Case 3.
Yes, I'm here.
Hello. Right. So let's see. So a patient, where is the tumor? What is the likely diagnosis and why? And which nerves may be affected? So this is a T2 weighted image. You can see the high signal. The question is, where is it? Where is
I think it is at the left cerebropontine angle.
Excellent, well done. So here is the pons. This is the cerebellum. So pons and cerebellum, the angle between the two, cerebellopontine angle, very good. Inside or outside the brain?
I think it is outside the brain.
Good, very good. Now, if I just carry on going down, this is after we've given contrast. Is it enhancing?
It's enhancing.
Good. Now, what are 3 tumors? Do you know 3 tumors that can occur in the cerebellopontine angle?
I think those would be the acoustic neuroma.
Very good. Yes.
It can also be a meningioma.
Very good. Well done. The third one is actually quite rare, to be honest. But do you know a third rare tumor that occurs there?
Ependymoma.
It can occur there, yeah. More frequently, probably the epidermoid, but that's quite a rare tumor. Okay, so the most common tumors that enhance at that site would be meningioma or an acoustic neuroma. Now, which of those 2 do you think it is, and why? I'll show you that image. That's the clue. Or even if I go back to T2, that image, that one.
I think it's an acoustic neuroma.
Good. Why?
Because there's something arising from the internal acoustic canal.
Good, very good. Good. So this is in the cistern here, but there is extension here. And this tongue of tumor is actually growing along the internal auditory canal. Do you know what that little white thing is here and here? Does anybody want to pitch in? Does anybody know what that is? And does anybody know what that is? Anybody want to guess? Venus, do you want to have a guess? Or Natalie, do you want to carry on guessing?
Can it be the nerves?
Yeah, the nerves don't tend to be white. So because it's white, it means it's CSF or fluid. So to give you a clue, this triangular shaped area here is the petrous temporal bone. This bit is black because it's full of air. This is the mastoids and the middle ear. So what do you think this bit is?
Cochlea and semicircular canals.
Very good, well done. This is the cochlea. This is the vestibule. And you can see some of the semicircular canals. So this is the inner ear. And this area here is the internal auditory canal. So let me just show you. So you're absolutely right. This is growing along the nerves. Let me show you the anatomy. So here is normal. Pons cerebellum, cerebellopontine angle. And we can do a high resolution scan which will show you the 7th nerve and the 8th nerve. And although we call them acoustic neuromas, they're actually usually coming from the vestibular part of the 8th nerve, and they're usually schwannomas. So they're vestibular schwannomas, but we use the term acoustic neuroma. It means the same thing. So because it's growing along the nerve, you may find it only in the cerebellopontine angle or only in the internal auditory canal or both. But as soon as you see something in the canal here, you know it's probably an acoustic neuroma. And here's the canal. You can see the canal beautifully here, full of CSF. Again, cochlea, vestibule, semicircular canals. So another question, thank you. I'll throw it open to everybody. Or shall I? Let's see. Wing Yi, are you there, Wing Yi? Obviously, if you have an acoustic neuroma, it can affect the 8th nerve. It can affect the 7th nerve and give you a facial problem. What's the other nerve it can affect? What's the other cranial nerve that can be affected with an acoustic neuroma if it's very big?
Maybe the 9.
Yeah, it's a very good guess, actually. I mean, when you're looking at this, you would guess, it's probably going to be the 6th or the 9th. Actually, it's not. It's another one. So it's a good guess. What's the other one? Whoops, I haven't got it here. So I'll show you. The other one, I think, is the 5th nerve. The 5th nerve comes out just a little bit more superiorly. It's a very big nerve, and it often gets affected by these acoustic neuromas. Right, the last question now is to Avery. Again, where's the tumour, likely diagnosis, and why? This is the T2. T2. And I'll show you the T1. So it's enhancing again. If I go back to this scan.
So this is an abnormal T2-weighted, axial cut T2-weighted MRI of the brain. So I can see a left cerebellopontine tumor.
Yes, very good. So there's a tumour in the cerebellopontine angle, and we've seen it's enhancing. So the question now is this a meningioma or is this acoustic neuroma? Which of the two do you think, and why?
I think this is a more likely to be a meningioma.
Yeah, the first reason is because I've already shown you acoustic neuroma. But the other two reasons on the imaging,
it's not going into the internal auditory canal.
Well done. In fact, you see that better on the T2. Let me just go back. Can you see? Here's the internal auditory canal, cochlea, vestibule, semicircular canals. Here's the 7th and the 8th nerves. And you're quite right, it's going around here, but it's not going inside. So that is one of the clues. And the other clue is post-contrast is this one. What are we seeing on there? Does anybody know what I'm trying to get at here? Does anybody want to help, Avery? Gabriel, do you want to help Avery?
perhaps the fact that it's kind of tapering off the.
Okay, I'll cover it on the next one. So if I just go back to this one, the clue is that this is a tentorium along here. And can you see it's got one very flat edge and the other edge is bulging? And this is what it looks like anywhere in the brain. Maybe it's along the falx, not just the posterior fossa. Where it is next to the dura, it has a very flat edge and then it bulges inwards. And the other clue, I think probably Avery, could you see on this one, Avery or Gabriel? This is the other clue on here. I think this is what you may have been getting at, Gabriel, is it?
Is it like the contrast enhancing part kind of like tapers?
Yes. So you're trying. We call this a pigtail. So here it is here, and you can see the contrast. It's a bit like a pig's tail. And here. So this is where we've got some dural enhancement. Again, this suggests it's a meningioma. And again, no matter where it is, this is one of the signs that we would look for. So very good. Those are the two tumours. So just to show you again, here is the eighth nerve. You can actually see it divides into the cochlea and the vestibular components. Here's the seventh nerve. This is the internal auditory canal. It's full of CSF, so it's high signal. Cochlea, vestibule, rest of the petrous temporal bone. This, if you go a little bit higher, is the fifth nerve I was talking about earlier, coming off of the pons. And this is the other nerve that can be affected by the cerebellopontine angle tumours, particularly the acoustic neuromas. Okay, good. So I think everybody's presented now. Is that correct? Is there anybody I've forgotten? I have a checklist of everybody I'm asking questions, but I don't think I've forgotten anybody. Is that correct? Okay, in that case, we'll speed up a little bit and I'll just open the questions to everybody. Another MRI of a tumour, where is it and the likely diagnosis? So if you can all start typing, do you think this is cerebellopontine angle tumour? I'll tell you that. Do you think it's on the right side or the left side? Can you start typing? Right side or left side? Can everybody type? The tumour is on the right or the tumour is on the left? Right side, very good. Okay, good. So when you look at this, though, it's very difficult to see a tumour, isn't it? All you can see is that the cerebellopontine angle this side looks much more obtuse and this area is much widened, whereas the angle here is much more acute and this space isn't widened. So you've got the feeling that something's going on here. But on the T2, it looks a bit like CSF. And this is after contrast. I haven't shown you here. It didn't enhance. It looked the same. Does anybody know what tumour can occur in the cerebellopontine angle and look like that? So it doesn't look anything like an acoustic neuroma. It's not enhancing. It doesn't look like a meningioma. It's not enhancing. What tumour could that be? Does anybody know? Yeah, this is the epidermal. They're not very common, but it's just this would be the third common tumor. The third tumor to occur at this site. The thing about them is that they look a little bit like, it's best to think of them like a ghost. You can't really see them, but you know they're there because they're pushing things out of the way. Can you all start typing? Can you think of 2 MRI sequences that we've already discussed that might be able to show you that this is not CSF, it's not fluid, it's solid? What 2 sequences would tell you this is not fluid, it's solid? Can you type for me? Good, DWI, good. So if it was fluid, there would be no restriction of diffusion. But if it was solid, there would be restriction of diffusion. Very good. Anybody else? Another sequence? Flare. Very good. So the flare sequence, any fluid, that high signal is suppressed. So when you've got rid of the high signal from the fluid, if there's anything left, That's not fluid, it's solid tissue. And I think on this case, I've got an example of the DWI. So remember when I showed you the infarct, restricted diffusion looks the same, whether it's an acute infarct, whether it's a tumor. So it's the same thing. What you're looking for is high signal on the DWI image at a high B value and low signal on the diffusion map, i.e. the opposite to fluid. This is dark, this is bright. This is bright, this is dark, so the opposite to fluid. So you know this is not fluid because it's not behaving the same as the CSF. This is the solid tumor. Good. And again, here it is again, it's just to see all of those together. Case 6. Patient with headache and confusion. Describe 2 abnormalities and give the most likely diagnosis. For time, I'm just going to go through. This is CT before, this is CT after. The patient already had a shunt put in. You can follow the shunt as we go up. It's going out, it's going upwards. Okay, so I'm going to stop at that one. Does anybody want to type for me, or you can unmute yourself and give me a diagnosis, or maybe not a diagnosis, just describe the abnormality. Anybody can unmute or type. I've been talking for quite a few hours now, so any help from you guys would be great. Can you type or unmute? Rim enhancing lesion. Very good, Philip. Yes, absolutely. So we can see there's something here, and then after contrast, it's rim enhancing. What is the 2 pathologies that give you rim enhancing lesions? Abscess, very good. And the other one? Metastasis, yes. So tumor, like metastasis, very good. So it could be a tumor or it could be an abscess. What 2, if you were to go to MRI, what 2 sequences could you do on MRI that might help distinguish a tumor from an abscess? What are the 2 MRI sequences that can help distinguish tumor from abscess? Good. MRS and DWI, very good. Absolutely right. Now let's go back to this one though. On this scan, do we have any other clues as to whether it's likely to be a tumor or an abscess? And for that one, I want to show you this image. Does anybody want to unmute yourself and describe what we're looking at after contrast on this image? Anybody there, or shall I ask somebody?
Is it basal cistern enhancement?
Very good. Well done. Absolutely. So if you go back here, agreed it looks a little bit hyperdense, yeah? But not to the same extent as subarachnoid blood. Blood would be much brighter than this. What we can say on here, though, is that we can't see the black CSF space anymore. We've got some CSF in the sylvian fissures, but around the midbrain here, we can't see the CSF. And after contrast, it's enhancing. It's a bit nodular. There's even enhancement in the circle of Willis and along where the vessels are. Now, what anatomical structure could be enhancing? It's not CSF, is it? CSF is not going to enhance. So what could be enhancing? If you go up as well, here it is, all enhancing here. All of it, look at this. All around the circle of Willis, all of very nodular and thick. What's enhancing here? Anybody want to type or unmute yourself? Anybody? What's enhancing? Natalie, you want to carry on? You want to guess?
Meninges.
Good, very good. Absolutely. This is the leptomeningeal enhancement. So now, what are we thinking of? What pathology are we thinking of with enhancement of the basal leptomeninges? Natalie, you want to carry on?
Is it meningitis?
Good, yes. In fact, this was a TB meningitis. So the patient had a TB abscess and they had meningitis. Good. So let me ask a question now. Stephanie, are you there, Stephanie?
Yes.
Yes. Why do we do CT scans in patients with suspected meningitis? So you have a patient, they've got maybe confusion, a bit of fever. When you feel their neck, they've got neck stiffness. Why do we do, and we suspect meningitis, why do we do CT? What's the reason for doing a CT scan in a patient with meningitis?
Like to look for any abscess as well? I don't know.
Yes, make sure there's an abscess, but how do we make the diagnosis of meningitis? Yep, somebody's typing here. Absolutely, to do a lumbar puncture. That's right. Well done, Carol. So basically, if you do a CT scan, even with contrast, it could be completely normal in meningitis. The meninges don't always enhance in meningitis. So CT is not to make a diagnosis of meningitis. The reason for doing the CT is to make sure there's no space-occupying lesion that it would make it dangerous for you to do a lumbar puncture, because a lumbar puncture is how you make the diagnosis. It's not just diagnosis, but you need to know what the infection is, so you know which antibiotics or which treatment to give. So the diagnosis is based on lumbar puncture. What happens if you do a lumbar puncture in someone with a space-occupying lesion? Herniation, absolutely. So the brain, if there's increased intracranial pressure, the brain can herniate. So probably in this case, you could see that there was already an abscess. And so this is a follow-up, but having found an abscess, it's probably why they put a shunt in from the top and took the CSF out this way, because it's safer. Okay, so we're looking for space-occupying lesions that means it's not safe for you to do a lumbar puncture. Good. Okay, moving on. I think we're nearly done. Case 7, young lady, previous episode of blurred vision and arm numbness. She now comes with left leg weakness. What's the abnormality in the diagnosis? This is T2, like this. So I'm just going to ask, I'll go back to this one. Any of you who can draw, can you draw around any abnormalities that you can see on this scan? Any of you with the drawing facility, can you draw around anything that looks abnormal on this scan? Good, well done, absolutely. Yep. Any more? Anybody see any others? Yep, there's a second one here. Yep, any more? Anybody want to draw around any others? Can I convince you that maybe there's something here? There's something here. Okay, let's go down. All right, get drawing. Can you show me where are the abnormalities? Can you draw around these? Good, absolutely. Yep. Any more? Yes, keep going. Good. Any more? Yes, good. Yes, very good. So tell me one sequence which would make it easier to see these abnormalities. What sequence would we could do that would make it easier to see the abnormalities? Flare, good. So if we did a flare sequence, we would get rid of all of the CSF here. Some of this might just be little perivascular spaces. What is left would therefore be these lesions. Okay, everybody type in view of the history. What's the most likely diagnosis? If I can show you this one. This is actually a flare. So can you see how the abnormalities stand out? This is sagittal. You can see how we sometimes call this Dawson's fingers. They're fingers coming out. Diagnosis in view of the history. Remember the history. Just go back. This is the history. If you've got that history, you have that MRI, what do you think the diagnosis is? Anybody? Type for me. You can all type. Yes, MS. This is probably MS. So let's just quickly go back. This scan on its own is non-specific. There are lots of things it could be. If it's an elderly patient with hypertension, maybe this is your small vessel ischemia with the lacuna infarcts. It could be infection. Maybe you live in an area where there is, for example, Lyme's disease. Maybe this patient's got cancer, and when you give contrast, you'll see all this is enhancing and these are metastases. Or in this case, this is demyelination due to MS. So again, it's not specific. You need to put together the image and the clinical history to come up with the diagnosis. And just to show you as well in MS, I've just shown you this one. This was a very obvious lesion. We often give contrast because the patient can have old plaques and new plaques. And obviously we want to know how much of the disease is new. And the new plaques will enhance, whereas the old plaques do not enhance. So the enhancement tells us whether we're looking at active disease or old inactive plaques. Okay. Case 8, the final case. Young man, leg weakness, sensory level. Where's the abnormality and suggest a diagnosis? So I'm showing you this just to reinforce that if you're worried about spinal cord symptoms, the imaging modality of choice is MRI. On this sagittal MRI, this is a T2, a T1, and a T1 post-contrast. Now, the possible causes depend very much on the site of the abnormality. So lesions in this area are divided into, first of all, extradural and intradural. Extradural means outside the dura. So we're talking mainly about the vertebral bodies or the posterior elements, so the bone, or the discs. So, for example, if you have a bony metastasis, it can make the spine expand backwards and it can compress the cord, and the patient comes along with spinal cord symptoms. If you have a disc, it can prolapse back, spinal cord symptoms. You may have degenerative disease, you may have osteophytes, you may have disc prolapses, narrowing and compressing the cord. So all of those would be extradural. The second group is intradural, so inside the dura. And that is divided into intramedullary, which is the cord. You can see the cord here. And extramedullary, which is outside the cord. The extramedullary, the best thing to think of it is a bit like your cerebellopontine angle. So the tumors that can occur there would be meningioma, and of course, because the nerves are coming out, nerve sheath tumors as well. Other things to think about would be if you have a brain tumor, particularly children, that tumor can drop the metastases down the CSF. So when you're dividing it, you divide it first into extradural and intradural. And then if you think the problem is intradural, you have to further divide it into intramedullary and extramedullary. For intramedullary, the causes are very similar to those we've discussed in the brain. So anything in the brain could cause an infarct, ischemia, trauma, MS plaques, tumors. The same sort of problems inside the brain can occur in the cord. Now, what I want to know from everybody is this patient's abnormality. I want you to tell me, is it extradural or is it intradural extramedullary or intradural intramedullary? So there's three choices: extradural, intradural extramedullary, or intradural intramedullary. Can you all start typing? Where is the abnormality? Extradural or intradural? And if you think it's intradural, is it intradural extramedullary outside the cord or intradural intramedullary inside the cord? So intradural, yeah, I agree it's intradural. And Carol has said intramedullary, absolutely. Can you draw around? Any of you who've got a drawing capability, can you draw around where you think the abnormality is? Can you draw around it? Good, very good. Good. So there is actually, I'll tell you, this is a tumor. You really can't see it on the T1. A bit like all those metastases you can see in the brain, very difficult to see on the T1, but you see it afterwards. This was actually a primary spinal cord tumor. But note also, there are all these cysts above it. So the cord is expanded. The cysts go up here and down here. These are cysts associated with the tumor. Of course, another abnormality that can occur in the cord is a syrinx. But in this case, this is related to the tumor. Very good. Okay. Everybody type for me one pathology that can be intradural and extradural. Which pathology can go from inside to outside the dura? From your anatomy. Which pathology, which normal structure passes through the CSF space intradurally, pierces the dura, and then goes outside the dura? If you remember which normal structure can do that, then you can work out what pathology will do that. Nerves, very good. The nerves. So which pathology of a nerve do you know of? Carol, which pathology of nerves do you know of? Anybody? What pathology? What pathologies occur along nerves? Good, nerve sheath tumor, very good. Most of these are neuromas. They're not that uncommon. If you've got multiple of them, multiple nerve sheath tumors, what condition do you think of? A patient with multiple nerve sheath tumors, maybe they've got meningiomas as well. What condition will we think about then? What inherited condition makes it more likely that you'll have good neurofibromatosis? Yeah, so usually the NF1. Yeah, neurofibromatosis, very good. Okay. Cool. Anybody have any questions about the miscellaneous tumors and infection? Any questions? You can unmute yourself if you have a question. No questions? Okay. Sorry, it's a very long tutorial today. I have a few quiz questions. If you need to go, by all means go. If you want to stay, I'm just going to show you a few questions. Maybe I think somebody's drawn around the tumor here. If you could remove that one. Whoever's drawn around the tumor here. There's a white line around the enhancing part of the cord. Thank you very much. Good. Okay, so let's if you want to hang on, let's go. I'll just quickly go through, show you a case. Diagnosis. I'm going to do this very quickly. Diagnosis. So just jot it down on a piece of paper. In fact, this patient's got two pathologies, so if you're looking very carefully, can you see a second pathology? Okay, number two. Oh, so this is the same patient, same patient. Okay, same patient again. And same patient again. And again. And again. So let's start at the top. We're going to go down. What's the pathology? And can you see another pathology? Okay, let's move down. Number 2, diagnosis. And I'll tell you, there's some blood here. Where is that blood? And is there mass effect? Okay. Moving on. Diagnosis. Someone with trauma. Diagnosis. Number 4, diagnosis. This is a patient with focal neurological deficit, acute onset. This probably happened a couple of days ago. Okay, number 5. This patient is coming with right-sided hemiparesis. Right-sided hemiparesis. Okay, next one. Number 6, the patient looks like this and like this. Same patient. This patient has come in with a left hemiparesis. So it looks like this and this. I'll show you that one first, like this. And like this. Moving on. Patients come in with a right-sided hemiparesis. Can you see any abnormality? Okay, diagnosis. And what investigation would you do next? Or what sequence would you do next, rather? This is an MRI, T2, T1 post-contrast. Patient has some hearing loss, a bit of a headache. What other MRI sequence would you do? Patient, a road traffic accident. I'll tell you, this patient's got contusion. How many sites of contusion can you see? How many sites of contusion can you see? Diagnosis. Sorry for going quickly. Just this is before contrast. This is before contrast. The patient's been given a contrast scan. Can you give me a diagnosis and the cause? Yeah, last one. That's it. I think, yes, okay. Right, should we go over the answers? So can you all start typing for me? What was the diagnosis in this case? Everybody start typing. If you can type as quickly as you can, we can then finish. Diagnosis? Epidural hemorrhage. Very good. Anybody else? Any? Good. So we have biconvex, hyperdense lesion outside the brain. This is an acute epidural hemorrhage. I want to ask you, is this in the posterior fossa? Is it supratentorial or is it both? So infratentorial, supratentorial, or both? Can you type for me? Both. Yes, well done. Both. Is that unusual for an epidural to be both? Gabriel, Dominique? Oops. Sorry.
Probably unusual.
Yes, that's good. Okay, so you're right. It's not very often. It's not often we see it, but we can see it. And so, just to remind you, you remember I said that the subdural doesn't cross the forks, but the epidural. Sorry, let me just. But the epidural can. So not only can it cross the dura along the falx, it can also cross the dura in the tentorium. So the epidural can go from above to below. Now, just to check your anatomy, because it's not always easy. If I go down, this is clearly the posterior fossa. You've got the bone here and a little bit of the tentorium here. And then as we go up, the tentorium is tent-shaped tentorium. So it's a bit like standing up in a tent. As you go up, the tent gets smaller and smaller until you hit your head on the top of the tent. So as we're going up, the tentorium is getting smaller. Now at this level, you've lost the bone and you can just about see the tentorium, but it's not always very easy to see. As we go up, the tentorium is the sides of the tent are getting closer and closer. So it's just this part is the posterior fossa. This is the occipital lobe. Keep going up. You can just about make out that this would be the posterior fossa. This is the occipital lobe. Keep going. Now at this stage, we're starting to come into a line here, which is easier to see here. This is the top of the tent. This is the straight sinus. And so at this point, on both sides, we're in the occipital lobes. So this is supratentorial. This is now infratentorial. Does anybody know which vessel we've damaged? Which vessel would be damaged? Because it's nowhere near the middle meningeal artery, is it? Which other major vessel has been damaged in something at this site? Dural sinus. Good. Which one? So it's a venous sinus. Which venous sinus is at that site? So this is the transverse venous sinus. Remember, if I go, you can see it from the side, the sagittal sinus comes at the top and around, and then the transverse sinus comes on both sides around the posterior fossa here, and then down the sigmoid and into the internal jugular veins. So this is the area that you would expect the transverse venous sinus. How worried are you about this patient on a scale of 1 to 10? How worried are you about this patient on a scale of 1 to 10? Can you all type? Not very worried, 1. Extremely worried, a 10. A 9. How worried are you about this patient? 10x. Okay. Anybody else? Yeah, I was going. You're extra 7. Oh, I'd be much more worried, Carol. Anybody else? You're actually. In fact, this would probably be a 10 plus. Number 1, who said, is epidural. So they can suddenly change shape. So already you're up near a 10 because you're worried. In fact, but then mass effect. It's not so easy to look at the mass effect here, but there is some. You can see that the fourth ventricle is compressed. But the other reason I'm putting it as a 10 plus is this is in the posterior fossa. The posterior fossa is a very tight space. It has a little gap at the top for the tentorium to go through and a little gap, the foramen magnum below. It doesn't take a very big epidural to fill up that space. And once you compress the brainstem and you can herniate the cerebellar tonsils, which further compress the brainstem, the patient can stop breathing. So this one is really, really serious because it's in a very tight space. Okay. The other thing to note is that there was a little bit of hemorrhagic contusion inside the brain, possibly contra-Q, probably trauma here. The brain's gone forwards. It's hit part of the sphenoid ridge here. So this is probably a contra-Q hemorrhagic contusion. Okay, next question. Everybody, or maybe I'll quickly, just to save time, who can I ask? Michelle, are you there? Diagnosis? Michelle, diagnosis?
I'm actually not sure.
Yeah.
Blood, like what the location is.
Okay. For this one, do you see any other blood?
Also a subdural on the right.
Good. So we've got an acute subdural crescent, so how is it crescent shaped? What happens to the subdurals when it gets to the midline? Can it cross to the other side?
No.
No, that's the epidural, isn't it? So what does it do?
It collects in the venous sinuses.
Or not the venous, but it's not in the venous sinuses, but it can come back along the faults. So an subdural can come back along the faults. So this is probably just a continuation of the same subdural. And remember, non-accidental injury, children in particular, may only have blood here. Okay, quickly ask Grace, mass effect, yes or no? Mass effect, Grace? You're probably all tired. I am tired. It's hard to keep thinking, but Grace, mass effect?
There's no midline shift.
Yes.
But I think the ventricles on the right is a bit compressed.
Excellent. Well done. Very good. So the ventricle on this side is smaller than that side. Now, this ventricle might be normal for, well, even for you, it's probably a little bit big. But for this patient normally, this was an elderly patient. So this patient normally has large ventricles and large sulci because they got atrophy. So for this patient, even though the ventricle is smaller than that on the opposite side, so there is some mass effect. So yes, well done. Okay, next one. Dominique, diagnosis?
I think this is, as we can see, the sphenoid and the right mastoid.
The mastoid, this is hard. The patient's twisted, which is why we can't see the mastoid. But I understand why you thought the mastoid. Mastoid's probably okay, but you're right. What's wrong with the sphenoid sinus?
There's an air fluid level.
What does that mean?
Possibly skull base fracture. Or
so even if you can't see it, possibly skull base fracture. What sort of fracture is a skull base fracture that goes through the sphenoid sinus?
Compound fracture.
Compound. So what treatment might you give?
Treatment.
If it's compound.
Surgery.
No, it's so surgery for depressed fractures maybe, but this one, if the CSF can come out, what could go in?
Antibiotics, sorry.
Antibiotics, yes, very good. Does anybody see the fracture here? The answer to that is no. It's very difficult to see the fracture, but can anybody, maybe I can ask somebody, let me ask James, can you give me a clue to where the fracture might be?
Hello.
Yeah, James.
Is it the petrous part of the temporal bone?
I know why you're saying that, because it's quite asymmetrical. I tell you, it's not there. Can you give me any other clue? If I give you the clue, we're looking in the frontal region. What clue in the frontal region might tell you there's a fracture? We discussed some of these secondary clues. Not easy. Anybody want to help James?
Maybe some soft tissue swelling.
Good. Well done. Which side, right or left?
On the left side.
Yes, that's why we got this thing. How's it here? The soft tissue. So this is the roof of the orbit. So just above your eye. Here, no soft tissue swelling. Here we've got a lot. So we're going to focus on this area. Anything else in this area that is there that shouldn't be there? These are the sinuses, so this is okay.
Some air.
Good, well done. There are those little pockets of air. And that gives you a clue. In fact, it's hard to see, but that was the fracture. And as you went through, I haven't got the other images, you could actually follow the fracture. It went along the roof of the orbit, and then it dipped back into the sphenoid sinus. So this is just to tell you the fracture's not always easy to see, but look for those other clues. Very good. Next one. Diagnosis. Alvin, what's the diagnosis for this one? Alvin, are you there? Not here? Okay, Carol, can you help Alvin out? Carol?
Hello. I think it's a PCA infarct.
Good. Very good. Well done. So you can see very grey edge, not much pathology would do that. It's involving maybe a bit of the grey matter is okay here, but at this part along the forks, you've lost the grey matter, so grey and white. It's quite hypodense, isn't it? So it's not really, really acute. It may be more subacute, and it's in the occipital lobe. So absolutely, this is a PCA territory infarct. Well done. Oh, this was a hard one. I gave you only the history of a right-sided weakness. Feng Ching, are you there?
Yes.
Yes. Do you want to have a go at that? This is not easy. If you're struggling, maybe I can ask Marcus to try and help as well. Marcus, are you there as well? This is not an easy one. So the clue is that the hemiparesis was on the right side. So you've got to look carefully on the left side. This is something we haven't discussed yet. Okay, so someone said that
MCA.
Yes, what's wrong with the MCA? You're absolutely right.
Oh.
Is it got a funny density, the MCA? Hyperdense, very good. Yeah. So if you look, this again is the circle of Willis. Remember I said it always looks like a body with a little bit of a head. Here are the arms coming off, which are going off to the middle cerebral arteries. And then the back here coming around the cisterns of the legs. This is the suprasellar cistern. This is where the circle of Willis is. The MCA comes off on each side. And on this side, you can see it's hyperdense. Now, this is not an easy sign because as you get older, you can have calcium in the arteries. So it's not always easy. This here is the tentorium, which is a bit calcified. But in this setting, with that history, you will be worried that this is a thrombus and this is the dense MCA sign. And in fact, a little bit later, you can see the patient has now developed the infarct in the MCA territory. So sparing, the ACA territory. It's involved in the posterior part of the frontal and the anterior part of the temporal lobes. Good. Okay, moving on. Daisy, what is this and this? Daisy, if you're there, what is this hyperdense area here and here?
Maybe some blood.
Good, it could be. So it's hyperdense. So very good. You're going through your list of hyperdensities. What's the chance that someone would have a hemorrhage there, bing, and then a hemorrhage on the other side, bing, probably about the same size and the same time? Is that likely?
Not really.
No. So, okay. So let's go through the list. Is it likely to be bone?
No.
Calcium?
Maybe.
Yes. Good. And then foreign body, again, not likely. So this is calcium. Whenever you see things that are bilateral and symmetrical, it's often physiological or metabolic. And this is just what we call basal ganglia calcification. Here's the lentiform nucleus. It's in the globus pallidus. We commonly see this. We often just ignore it. And this is a little bit more than we often see. And there are conditions related to the calcium that can do this. But this patient came in with weakness on the left side. So this is not the cause of the abnormality. Natalie, what is the cause of the abnormality? What is the cause of the left-sided weakness?
I can see some hypodensity over is it internal capsule?
Very good. Which side? Right or left?
On the right side.
And involving internal capsule. Anything else it's involving from the anatomy? Any of the nuclei?
The lentiform.
Very good. Well done. So there is a lacuna infarct here. It's in the lentiform nucleus. But here is the internal capsule, and it's extending into the internal capsule, which is why even a small lesion at such a vital place can cause a hemiparesis on the other side. So this is your small vessel disease. Patients who are hypertensive or have diabetes. Good. Well done. Moving on quickly. Number 7. Where did we get to? Let's see. Tammy? Tammy, can you make a diagnosis on this?
I think there is some high ISO density over the left occipital and parietal region.
Yes. What about frontal and temporal? So stay here. Is it in the temporal lobe?
Yes.
Yes. Good. So there's something here compared to here. Frontal?
Also.
Good. Well, it's very subtle. What do you think this is?
Maybe an infarct.
Yes. Which territory?
All three.
Yeah. No. Which artery? Which artery? Sorry. Which artery is likely to be involved? It's maybe not. It's sort of more posterior parietal here. I think the occipital is probably spared. So which artery is this area here? MCA, ACA, or PCA?
MCA.
Good. This is an acute MCA infarct. It's quite subtle, so well done for picking it up. You can see you've lost the grey-white matter differentiation around the edge. But equally, if you go to the basal ganglia, we can't see this external capsule anymore. We can't see the lentiform nucleus. It's extending all the way in, even into the caudate head. So this is an acute MCA infarct. Which technique picks up infarcts quicker than CT? More early, rather? Earlier than CT?
MRI.
Good. And which sequence on MRI is particularly useful? For the early infarcts? The DWI, yes, diffusion weighted imaging. So we will do DWI in the acute infarcts. Good, right, let's move on. 8, diagnosis. Derek, diagnosis? Are you there, Derek? Nope, gone. Okay. She, him, diagnosis? Right or left side? Centered on the right or the left? I agree it's crossing the midline, isn't it? But centered, bigger on the right or the left? Good. And so there's something here. The signal intensity is similar to CSF? Is it same as CSF? Yes, okay. But CSF wouldn't be expected to push things. It's compressing, isn't it? It's compressing the brain. So what do you think? If this is a tumor, what would that tumor be? It could be, but what tumor in particular is from in the cerebellopontine angle, we had 3 tumors. Meningioma, the other one is, acoustic neuroma, and the third one is the epidermoid. Yeah. Which 2 of those tumors enhances after contrast? Good. So this one is not enhancing. So this one is probably the epidermoid. Good. It looks like a ghost, doesn't it? You can't see it, but you can see it pushing things around. What are the 2 sequences that might show it up better? Yep. Good. Good. Well done. The flare and the diffusion. Very good. Well done. Okay. Everybody type for me. How many areas of contusion? 1, 2, 3, or 4? Come in. 1, 2, 3, or 4. You can all type. 1, 2, 3, or 4. I may have to speed up because I've got something else in a minute. 1, 2, 3, or 4. You can all type. So this patient has had trauma. They have contusion. How many sites of contusion? 4 from James. Anybody else want to hazard a guess? Philip, you want to give me a number, Philip?
I also think 4.
4. Okay. Yeah. Okay. Do you want to draw, Philip and James, do you want to draw around the areas? Can you draw around them?
Sorry, I can't figure out the drawing.
Okay. Philip, you can't draw. James, can you draw? Good. So very good. So there's the largest areas in the frontal lobe. It's mixed density. So this is got hemorrhage and no hemorrhage. Contusion. The other frontal lobe, which is just hypodense. So this is just contusion. Keep going. Yeah, this is a bit harder. I think this is just the white matter here. And this actually is the CSF around the going into the Sylvian fissure. Here again, can you see we've got the suprasellar cistern, looks like a body with a little head and the arms and the legs. Okay, so third area, there's 3 areas, the answer is. There's 3 areas. Where's the third area? Just to check. Well done. Very good, James. So hemorrhagic contusion, mixed density. So mixed density, hemorrhagic contusion. Hypodense only, just contusion. Mixed density, hemorrhagic contusion, 3 areas. Remember, contusion can be at the site of trauma or opposite to the site if it's contracute. Good. I just tell you, this is obviously a depressed, comminuted fracture, and there is air outside the brain, so it's compound. This patient needs surgery to lift the fragmented bone and repair the dura. Again, for time, I would just show you, this is before contrast. So because no contrast has been given, this is blood. Blood in that suprasellar cistern. Here we are, here's the body, the little neck going up to the head, the arms, the legs. This is in the suprasellar cistern, extending along the middle cerebral arteries, along the anterior cerebral arteries, back along the basal cisterns. We would normally, on subarachnoid hemorrhage, do a CTA next. We can do a 3D reconstruction. But in this case, even on the anatomical images, you can see that there is an enhancing aneurysm. It's actually in there. So this was an MCA aneurysm. Remember, there can be multiple, they can be familial. Learn all about subarachnoid aneurysms and hemorrhage. This one I haven't shown you. Just quickly, what is A? Ivy, what is A? This is a coronal section, MRI of the pituitary region. Ivy, what is A?
Is it the pituitary?
The pituitary is under here. I'm looking at this thing along here. I'll just tell you, this is the pituitary fossa, and there is a big tumor in the pituitary fossa, which is extending into the suprasellar region, and it is compressing this structure, which is A.
The optic chiasm.
Good, optic chiasm. If you examine the patient, what might you find with their visual fields?
By temporal hemianopia.
Very good, well done. B, Tom, what is B?
It looks like a vessel, so can be internal carotid artery.
Good. This is the internal carotid artery. Good. Surrounding it, this enhancing area is the cavernous sinus. So in the cavernous sinus is B, the internal carotid artery. Plus, what is C? These little dots. What is C? Wing Yi, what is C?
Possibly the nerve in the carotid.
Good. Which nerves go through the cavernous sinus?
The 3, 4, and 5.
3, 4, and 5. Good. Is it 3, 4, 5, and
6?
6. Is it all branches of 5, or is there one branch of 5 that doesn't go through it?
It doesn't go through.
Sorry.
The third branches of.
Good. Yeah, absolutely. So it's the 3rd to the 6th cranial nerves, except for the last branch of 5. The V3 doesn't. Good. D, what is D? I think I've asked everybody questions. What's D? This air-filled area below the pituitary fossa?
Sphenoid sinus.
Sphenoid sinus, good. And what is E? An air-filled level below the skull base, just below the sphenoid sinus?
Nasocavity.
Good. It's a nasocavity. Yeah. No, I think just coming back a little bit, we're actually coming into the nasopharynx, just behind the nasal cavity. Reason I show it to you is that nasopharyngeal cancer here is not that uncommon, and the cancers can grow into the sinus and into the cavernous sinus. And sometimes these patients may come along with cranial nerve palsies because the nasopharynx is very close to the cavernous sinus. Last one. This is just a CT angiogram to show you the vertebrals, the basilar, the posterior cerebrals coming off. Then we've got the anterior circulation and distal internal carotid artery dividing into middle and anterior cerebral arteries. The two sides are joined by the anterior communicating artery, and the anterior circulation is joined to the posterior circulation by the posterior communicating artery, which is not so easy to see. And in this patient, you can see that there is a swelling, a dilatation of the vertebral artery. This is not a common sight, but this was a vertebral artery aneurysm. Much more common would be to find aneurysms related to the distal internal carotid and the middle cerebral. That's probably the most common. I have to finish there because I get tired, forget that one. Okay, I think we are done there. Does anybody have any quick questions? That was a very long tutorial. No questions? No? Okay. No, my time, no play. It's a pleasure teaching you. Just to say, I think you've got some more tutorials coming up. On Friday morning, you will have the chance to go around the various modalities. So you need to turn up and speak to Judith, the secretary. It's first come, first served, because we can't fit you into everything. If you are in just the control room, you do not need to fill out the logbook for patient contact. If, however, you are nearer to the patient, sometimes in the interventional room, you might be nearer, although I would prefer it if you can stay in the control room, it would be better. But if you do have any direct patient contact, or you end up clerking the patient in or something, then you would need to fill it out. Otherwise, you don't. The idea of this is twofold. It's one, when you're there, make sure you've downloaded all the information about patient preparation. So, for example, if you're in MRI, you can see what is needed. The radiographers and the nurses are there. They can answer your questions. You're there to see what it's like for the patient having the scan as well. The doctors may not have chance to go through a case with you. They may possibly show you one case if you're lucky, but sometimes they're very busy. Most of this is so that you're with the radiographers and the nurses. And the other reason for being is that be very polite. This is your chance to interact with staff. And when you become doctors, the better you can interact with the staff, the easier life is, because everybody likes to work with people who are helpful. And so be very polite and very pleasant. This is your chance to start to interact with the staff. And then in the afternoon, you'll have a quiz. If you fail the quiz, you don't fail radiology. But if you have found that there are areas you're not doing so well, go away and revise them. And finally, the whole idea, I didn't get a chance to greet you at the beginning, but the whole idea is not really necessarily to make you radiologists. It's to make you aware of all the pathology that you need to know about by the time you qualify. Number two, to make you aware of the modalities of looking at various pathologies so you know what to ask for, and the importance of a very good history when you're filling out the form. And then thirdly, to make some diagnoses, mainly on CT for, for trauma and for stroke. With that, I think I've talked enough. Can't talk anymore. So thank you for listening, and I hope you enjoy your tutorials tomorrow. Thank you.
Thank you very much.
My pleasure. You're all still here, so very good. Thank you.
Thank you.
Bye-bye.
Thank you.
Bye. Bye. Bye-bye. Thank you.